This one? Thank you, Mr. Minister. Welcome to the 16th European Healthcare Fraud and Corruption Network International Conference. This year, it's a very important one. It's a different one because you're celebrating your 20th anniversary. Congratulations to all the members for these 2 decades of hard work fighting fraud in healthcare since the network's foundation in 2005. Welcome you all to Madrid. I think some of you have just arrived, and I hear you've come from very far, from Zambia, from the United States, and from the Ukraine. We have 10 people from the Ukraine Ministry of Health where I honestly don't know how healthcare can be dealt with in a war situation, unfortunately still ongoing. Tomorrow they will tell us how they're coping. Welcome to the first of a 2-day conference, which will take place here in Spain's Ministry of Health, in the heart of Spain. Thank you for joining Europe's leading voices in healthcare fraud prevention, and a special thanks to the Ministry of Health for hosting this very important event. Spain, who has recently joined the network last year, I hear. I hear we have more than 100 participants, 115, I think, from around 16 countries and representing 45 organizations. EHFCN members, of course, healthcare experts, policymakers, leading figures from European and international institutions. You are all engaged in the fight against fraud and corruption in healthcare. This year's conference is entitled, as you can see, Fighting Fraud and Corruption in Healthcare from System Design to Enforcement, European Perspectives. We will analyse healthcare financing systems and how the different forms of financing, mainly fee-for-service or monthly salaries, can affect fraud and corruption in healthcare. I must say, I am absolutely shocked to hear that there are organised criminal networks aiming to exploit the healthcare sector. We will hear different voices. We will see how fraud finds its way through different healthcare models, and we will exchange strategies and share best practices in this very important fight. Thank you all for shaping a more transparent and resilient healthcare system. Today is going to be a long day. I think you have the program. I'm sure you have all been given this program. And I would like to tell you that there is a QR code here where you can have access to the conference pack. And that's where you can see all the different speakers, the bios, so that you understand fully what they're going to be talking about. And very important, that's also the way to send questions that later will be answered by all the specialists. So, long day, as I said, but there will be, of course, nice and special breaks throughout the presentations, and, of course, a lovely lunch break. So, ready to begin? Let's begin. It's time to hear from our host. I've been told that thanks to her, Spain is now a member of the European Healthcare Fraud and Corruption Network. May I also say, in Spain, we have a very privileged and solid healthcare system. Please welcome Spain's Ministry of Health, Mónica García, who is actually a doctor, an anesthesiologist. Please come up, Mónica. And she knows firsthand how healthcare works here in Spain. Please.
So, thank you very much. Welcome to Madrid. Welcome to the Ministry of Health of Spain. They are president of the European Health and Corruption Network. They are Philippe. We knew years ago, I don't know if in 2018 in Berlin, when I was only a curious politician, anesthesiologist interested in corruption. And Philippe looked after me and further opened my curiosity about how fight against corruption. So thank you, Philippe. It's an honor for me to be here. And today, as a Minister of Health, it's a real pleasure to welcome you on behalf of the government of Spain to the 16th European Health Fraud and Corruption Network. Thank you all for being here today, for joining us, and for trusting us to host such an important conference. Let me start by expressing my gratitude and appreciation to the EHFCN. 20 years of work promoting integrity in health systems and complex and essential tasks truly deserve our recognition and admiration. The theme of this year's conference, From System Design to Enforcement, perfectly reflects the spirit of this network. Understanding that integrity is not something you add at the end, but something that must be built into every part of the system, its design, its structure, and its culture. Just a year and a half ago, in May 2024, we launched the Observatory Against Fraud and Corruption in Health here in Spain. It was created with a very clear purpose: to strengthen transparency, integrity, and good governance in the health sector. And it was born from a strong conviction that citizens' trust in health institutions cannot be taken for granted. It must be earned every day through concrete action and accountability. In this short time, the Observatory has become a pioneering initiative within Spain's national health system and a reference across Europe. In fact, it was at last year's EHFCN conference that we first announced its creation. If that edition was about making a commitment, this one is about showing results. Today, we can share concrete measures, innovative methods, and tools that are already transforming the way we manage public health in the health system. Over this year, we have shown that integrity can be organized and governed. The monitoring committee of the observatory has already met 4 times, and we will hold another meeting before the end of the year. The observatory's plenary has also been active with meetings last September and this May, and another one planned before December to present our work on conflicts of interest. Let me highlight some concrete actions already underway. We have analyzed the public sector procurement platform to improve technical capacities and reduce discretion in fast-track procedures. We have proposed legal reforms to address special cases, such as gene therapy medicine, and to prepare a specific contracting guide for exclusive medicines. We have published the agendas of senior officials and included the list of temporary positions in our onboarding materials. And we have also improved public consultations and participation in the ministry's rulemaking process. These may sound like technical measures, but they have a deep impact. They make processes more transparent, involve civil society, and create a clear trace of every decision. In the area of alerts and prevention, we have advanced as well. Just 2 weeks ago, the National Anti-Fraud Service, Seneca, provided a specialized training that helped us develop a risk matrix specific to the health sector. We have reviewed potential conflict of interest in 9 departments of the ministry and set up an internal whistleblowing channel in our public foundation, ensuring confidentiality and professionalism for everyone who speaks up. We also understand that integrity is not only about control, it is also about communication. That's why the observatory now has its own communication plan, website, logo, and public declaration presented last year. Among all our innovations, one deserves a special mention: our new methodology for identifying and analyzing conflict of interest in the health sector, approved this May. It's a pioneering tool based on a detailed analysis of the responsibilities of leadership teams, and it organized the information into clear tables with reference standards, risk indicators, and observations. This work was done together with every unit, through personalized reports and meeting with the 9 departments and agencies of the ministry to identify sensitive areas and possible possible improvements. The goal was to promote internal reflection, institutional self-awareness, and prevention before risks will become real problems. From this evaluation, the Observatory's Secretariat made recommendations to strengthen institutional integrity through preventive actions, process adjustments, and early detection tools. The results are clear. We identified 314 risk indicators across 138 functions and recorded 264 measures already implemented. Measures already implemented and proposed 23 new actions for the next phase. This shows that integrity can be measured, evaluated, and improved. That it is not just a word, it's a daily practice. And that talking about conflict of interest is not a sign of mistrust, but of democratic maturity. The Observatory has also been included in Spain's 5th Open Governance Plan, approved in May, reinforcing our commitment to transparency and accountability. We continue to work closely with Seneca, developing a risk matrix tailored to their health sector in line with European standards. Such cooperation is essential. Only strong partnerships between national and European institutions can truly build a culture of integrity. Looking ahead in 2026, we will continue this work, creating practical tools for the 9 units already assessed and completing the national risk matrix. We will also hold the first Integrity Awards in health, recognizing good practices and showing that integrity also leads to better health outcomes. This conference gives us a unique opportunity to learn from each other, hearing from the WHO, from other governments, and from experts on European trends in procurement, compliance, and whistleblower protection. We also welcome new members to the network. Thank you and congratulations for joining this shared mission, because the fight against health corruption only makes sense if we face it together. Dear colleagues, integrity is not an extra layer we add to the system. It is the system. It's institutional design, it's technology for transparency, it's data for detection, trained people, and an ethical culture. It's also justice, efficiency, and trust, so citizens can believe in their public health systems. Spain takes on this task with humility and determination. That's why we created the Observatory, changed procedures, developed methods, measured risk, and shared results. And that's why we are here today, open to learning and collaboration. Thank you again to the European Health Fraud Network for your leadership, and to all the delegation present for your partnership and experience. I'm pleased to officially open the 16th European Health and Corruption Network Conference, and I warmly welcome you all to Madrid. Thank you very much.
Thank you very much, Minister, for your commitment. Thank you very much, Mónica García, Spain's Minister for Health, for your words. It's now turn to hand the microphone to the President. Let's give a warm welcome to Philippe Tavernier, the European Healthcare Fraud and Corruption Network's President. This conference could not be opened without him. We are all ears.
Señora Ministra, Secretario de Estado, estimadas delegadas y estimados delegados del Ministerio de Sanidad, honored delegations from Ukraine and from Zambia also, distinguished guests, dear friends of EHFCM. It's a great honor and pleasure for me to welcome you today to this international conference here in this so beautiful city, Madrid, and also here in this building of the Spanish Ministry of Health. So muchas gracias, señora ministra, por darnos la bienvenida aquí en su casa, si lo puede decir. Espero que no duerme aquí, pero ya vimos que encima hay un departamento para los ministros, pero espero que no está durmiendo por acá. We have come together with different backgrounds and expertise, but with one common goal: how to tackle fraud and corruption in healthcare so that all resources can be directed towards the most important aspect of our effort, and that is giving patients access to qualitative healthcare. All the members of the HFCN work on this every day, even if our efforts are not always visible. It's similar to health itself. It's often only when something goes wrong that it's noticed and we are called to account for it. Yesterday, we already spent, here also in this building, an entire day with the network. We exchanged ideas about the importance of prevention to avoid billing errors. We compared our powers and possible actions in cases of intentional infringements, and we identified areas where we can better collaborate. We also reflected on the growing trend of criminal organizations exploiting two fundamental elements of our healthcare system. The minister already mentioned one, trust, but there is another one, accessibility. However, we are not discouraged and have our response already ready. Transparency of processes, very important, an even greater focus on information sharing, and also international cooperation, what we are doing here. Today and tomorrow we want to focus on the link between healthcare financing models and phenomena in fraud. How can the design of certain financing models prevent or conversely encourage fraud and corruption? This conference is not only a meeting place for the exchange of knowledge, but also a breeding ground for new ideas, unexpected collaborations, and inspiring conversations. Now more than ever, as global news grows increasingly troubling, it's crucial that we reach across borders and strengthen each other. I would like to thank all the speakers and the organizers for the tireless efforts. Thanks to their hard work, we can today enjoy a rich program full of lectures, panel discussions, and most importantly, networking opportunities. I wish you an inspiring, fruitful, and above all, enjoyable conference. Let us make a difference together. You are most welcome and enjoy everything the Ministry of Health of Spain, together with EHFCN, have prepared for you. I thank you.
Thank you so much, Mr. Tavernier. Thank you for leading such an important network. Now, the conference has been formally opened, and as we are in Spain, I'm sure most of you want to know how the local system works. As I said at the beginning, we Spaniards are very lucky because we have an amazing healthcare service, completely free and very high quality. And to explain how it works, we have with us Mr. Javier Padilla, Spain's Health Secretary of State.
Thank you very much. It's really a pleasure to be here with you. I'm going to project one slide. I don't know if people in the media can give me access to the board. Okay. I guess maybe the first 2 or 3 rows are not going to see it really well, but you can turn your head and it's in the TV in the screen there. But I didn't want to be talking for half an hour, just you looking at me, at my face, without having any additional support. I've been set to try to explain you how the Spanish health system works, and I thought that maybe the best way to try to explain it was trying to make you know how the money is being followed across the whole system, in order also to identify what can be our hotspots, in order to identify where we are weaker in terms of fraud and corruption. First of all, is that in Spain we have a national health service, so our health service is financed through our general budget and our general taxes, but it was not this way for our whole history. In 1986, we approved our general health law. It was approved, led by a minister called Ernest Lluch. This room where we are is Ernest Lluch room in honor to this minister. And there we passed through a social security system to what we wanted to be a national health service. It wasn't a national health service till 1999, where our service was not financed through social security taxes, but through general taxes. And now we have a national health service. It's almost universal, and it's financed through general taxes. Even though we have, we could say, one parallel system. It's an heritage we have from our past, and it's a parallel system which is financed through individual social security taxes, but also by the general budget, and it's for public servants. We have this incoherent situation where public servants are having a system that is not the general national health system, and they have the option to receive private or public healthcare provision. This is something I think that it's like quite singular from our national situation, but it's something that it's happening. This is what we have here, the social security mutualism for civil servants. So, as you may see there, they are receiving and they are being financed by the Spanish government, but they have the possibility of receiving private insurance or public insurance. It's under their decision, even though the trend in the last years is that most of the public servants that are new public servants are deciding to receive the public service, but not the private one. So we also have another way of receiving the insurance is the people with double insurance, who have the public insurance and also they are paying and they are purchasing the private insurance. Now in Spain it's almost around 25 people who are individually or collectively, by means of their jobs, they are contracting the private insurance, but there are some regions where this percentage is far more above, and especially here in the community of Madrid, where the percentage of that is about the 40% of the population. 4 above 10 are purchasing their private insurance. So, in this slide, I think that we can see like a general landscape of how the money is being moved around our system. So we have the Spanish Parliament, who by the general budget approved, is giving the Spanish government the general budget, which is going to be transferred to the regional government. So the regional government receives the money from the general contribution, and they decide what amount of money is going to be dedicated to their healthcare budget. So the money transferred from the central government to the regional government is not money that should be automatically used for health purpose, but the regions have the autonomy, they have the competences to dedicate this money to health or to social services, to public construction, to whatever they want. So this money is dedicated to the departments of health and to the autonomic healthcare services. So once we have this this regional budget, it's distributed for the different services we have. In Spain, we have a primary healthcare-based service. It receives about the 14 or 15% of the general healthcare budget. We have the hospital services and we have the public health services. Each of them, the professionals are going to be paid in a similar but also with some singular characteristics. In primary care, the professionals, they got some of their earnings through the capitative system, so they are receiving a certain amount of the money they are paid because of the amount of patients they have under their surveillance, we could say. In the hospitals, all the money is through the salary, not depending, not the activity and not the capitation they have, because we don't have it. And public health, it's also the same as in hospitals. And we have another actor that I think it's also very relevant. It's not a public actor, but it really has a public service. It's the community pharmacies. The community pharmacies, they are earning their money in relation to the sales they are having because of the margin of the benefit they have for each of the sales they are doing. And they are receiving both public money for the drugs that are financed, but also private money, because the pharmacy is the only place where we have a shared cost system. So patients are having a co-payment, and the public finance, the public system, is also paying for some for most of the expenditure. In general, in what's referred to our pharma expenditure, 90% of our ambulatory pharma expenditure is given by the government, and 10% in general is given by the patients and by the users. So this is like our general landscape in what's referred to our health services. And also we have the private system. It's referred here as private insurance, but 3 out of every 10 euros that are spent in Spain come from private expenditure. 3 out of 10. But about 60% of these 3 out of 10 comes from co-payment of drugs. Okay, so it's not private healthcare, it's about the co-payments. And about 15% of this 33% comes from private insurance. So in our general private healthcare system here in Spain, most of the expenditure comes just for drugs, so it's included in the public service mechanisms, and just the minimum part is coming from the insurance, and the other part comes from the services that are not covered, especially for buccodental health and also for visual health. So we could say that in Spain, private healthcare gets many of the revenues they have by their connection to the public services. And I think this is very something that it's quite singular from our situation. Our system could be said like maybe quite a monopoly from the public healthcare, but there are some public-private situations and public-private contracts and agreements that make that 1/3 of the general revenue of the private healthcare in Spain comes directly from the public services. It comes by contracting just for making certain complementary services, that radiology or that certain surgeries or something like that, but also comes from our PPP and PFI contracts that have made that in many regions, especially in Valencia and the community of Madrid, we have like mortgaged some of the management of some of our public hospitals for 30 or 40 years, because private companies were doing the construction of some of our hospitals, and in addition they were having like the management in order to be getting the revenue because of a capitative payment they were receiving, or because they were having the exploitation for the complementary services like cafeteria, parking, and so on. So this is like the general landscape that we have for our private, public, where the money comes. It comes from the general budget. It comes to have the universal right for health coverage, but also a parallel system for the public servants in a system that is based on primary health, but where the most of the money is going to the hospital. But I wanted to put the focus on two other sections that, in my opinion, are especially important. One of them is related to pharma expenditure, because in Spain we have a highly decentralized system where the regions have the competencies on the healthcare provision, but we have a central co-governance together with the regions in what's referred to the approval in finance and reimbursement for everything related to drugs. And we know that one of the main drivers in the increase of the healthcare expenditure is by means of the increase in the pharma expenditure. So the decision on price and reimbursement is made in a commission where the Ministry of Health has the leading, but where the regions are also participating and deciding. But the negotiation is a competence of the Ministry of Health. So the Ministry of Health, we have the competence of the negotiation of the price and reimbursement. We get to a commission together with the regions in order to decide if this drug is going to be financed and under what terms it's going to be done. And afterwards, the acquisition is going to be made by the regions. So the decision is in a centralized way, but the acquisition is in a decentralized way. I think it's very important because it's going to say that the concrete contracts of the acquisition is not going to be made by the ministry, it's going to be made by the decentralized government, by the region. So we in the ministry, we have been establishing a high degree of transparency actions in what's related to the decision on price and reimbursement, but many of these transparency actions should be taken also at a decentralized way when talking about the contracts and the negotiation of these contracts. And the other thing I wanted to talk about is about how the healthcare workforce is related to the healthcare system, that I think is also one way of generating positive or negative incentives in the way that we are working. In general, everybody working in the public health system, especially in the centers that are directly given the provision under public health institutions, our relationship is about the public servants. So they, sooner or later, they are receiving stable and without no end public contracts, and they are public servants. It's something very different, for instance, to other places, especially in what's referred to primary healthcare, is very different to another national health service, for instance, the UK. But here in Spain, they are purely public servants. It's different in those hospitals which are managed by private concessions or by private enterprises, but which are managing public service. These workers, they have a private laboral relation with their contractors, and this is like this situation that we have between the workers which are working under the public managed service and the workers which are working under the private managed services. So to finish, I would like to outline which places in our system that I think that may be the hotspots in what could be related to fraud and corruption. First of all, it's related, very obviously, with public contracts. Public contracts related to drugs, to services. I think that it's been very popular, everything related to the masks to the face masks during the pandemics, but also related to technology. Increasing the transparency and the accountability in these contracts is one of the things that I think that is being done. The other thing is about the public contracts, but with a very singular way of contracting, is where you are mixing the construction of the public healthcare infrastructure. You are linking that to the possibility of exploiting the management in addition to a capitation that you are given. The second thing would be about the situation where some centers and some professionals are given about the private and public practice when they are compatibilizing both practice, and the possibility of doing some risk selection where public is acquiring the high-risk patients, but the private are giving the low-risk selection. The third thing would be about the revolving doors in the high mandataries and the high managers. I think that in Spain it's been in the news in the last days that, for instance, in a region in Andalusia, it's been given the under-counselor position to a person who was the medical director of a private hospital. This is something that is still quite common, so we have been putting the barriers in order that people who are in a high mandatory position cannot go to a private situation with conflict of interest. But the other thing, so taking the people from places where the conflict of interest could be very clear, it's something that is still happening. The fourth thing is about the pressure that many people in the management situation, management boards, are receiving from lobbies who are very specifically against public health purposes. I'm speaking specifically because when we are talking about lobbying in health, we always focus on pharma lobby, but I would like to also to outline the situation of the tobacco lobby and all the alcoholic beverage lobby. I think that yesterday it was published the ranking and about how countries are more or less influenced by the tobacco industry, and I think that this is something that we should be also focusing. I think that many works have been done, and the minister was also before outlining everything that has been done here in the observatory, but I think that afterwards you will have here to the director of the Independent Whistleblower Protection Agency. That is something that is being focused more broadly, not just on health, but I think it's also very significant action that has been taken. So I don't want to say anything else. I would like to thank specifically to the team here in the ministry that has made possible what we are doing here, but that has been pushing all the actions related to fraud and corruption related to health. So thank you very much, and it's a pleasure to have you here. Thank you.
Thank you very much, Mr. Javier Padilla, Spain's Health Secretary of State, for explaining how Spain's health system works. That wasn't easy, difficult job. We have a decentralized government in Spain, 17 regions with their own healthcare service, and that is sometimes challenging. Well, we're going to go down to business. We're going to go through different financing models and the diverse forms of fraud associated with them. And we're going to hear this from the World Health Organization. Please give a warm welcome to David Clark, a World Health Organization team leader in universal health coverage and health systems law.
Minister, colleagues, it's a great pleasure to be back in Spain. I was here, I think, nearly a year ago when we had some colleagues here from the London School of Tropical Medicine and Hygiene and from the observatory talking about the launch of the Spanish Observatory for Anti-Corruption. So it's a great pleasure to be back. So just to add that one of the other things that's happening globally in relation to this really important topic is there's now a Lancet Commission which is specifically looking at the topic of anti-corruption in health. And I just wanted to point out that some of the commissioners are here today. I'm one of the commissioners, and also two of my co-commissioners, Dina Balabanova and Neil Spicer, are up at the back of the room. So if you want to hear more about the Lancet Commission, I'm sorry to have this little plug for the Commission, but I think the reason they're here is to learn from you all. I think they're really keen to learn more about the success of Spain's experience, but also to learn from the people in this room about their perspectives on anti-corruption and make sure that that's reflected in the ongoing work of the Commission. So today, I'm going to talk a little bit about healthcare purchasing and how that relates to the anti-corruption topic. So in WHO, my role is to look after the governance aspects of WHO's work. And one of those aspects is looking at how we can address corruption in healthcare. I guess I'm more at the, thinking about the themes for the conference, more at the systems end of the spectrum. I'm not really a fraud person. I'm a health systems strengthening expert. So what I wanted to talk a little bit to do today is to talk a bit about an overview of health financing and procurement, strategic purchasing and the importance of strategic purchasing in health, purchasing methods and their consequences, and then I want to touch on WHO's work on corruption risks and the broader topic of public financial management. So today we're going to be talking about fraud in the health system, but public financial management is takes a broader lens, looking at how corruption affects the different aspects of the public financial management system. And this is some work that we're going to be presenting in December. WHO has an initiative called the Montreux Collaborative, which is about public financial management, and we'll be presenting the results of our work at that meeting. So at WHO, we focus on health financing in the bigger picture. So we're interested in how countries raise revenue for their health systems. We're interested in how countries pool funds. And we're interested, this is the focus of my talk today, on the purchasing of services. And in terms of thinking about this in a systemic way, this is a diagram that WHO has been using for some time now to explain the different policy tools that we discuss in relation to health financing, but also how those tools impact on the health system. So on the left-hand side of the slide, you'll see these boxes in yellow, the three main tools that I've just outlined in relation to health financing: revenue collection, pooling, and purchasing. But why are they important? They're really important because they contribute to better health outcomes. So if you go into the middle of the slide, you'll see the boxes which talk about why these tools are important. We want these tools because we want to increase equity in utilization and resource distribution. We want to improve quality. We want to improve efficiency. And critically, we want to improve transparency and accountability in health systems. So these are the key intermediate outcomes that we have when we come to thinking about health system goals. And then ultimately, we want to get better health. Now, I know this conference is about fraud and risk management, but I think we can't lose track of the sight of why we're here. We're doing work on fraud and risk management and corruption because we want to improve health gain, we want to improve equity in health, we want to improve financial risk protection, and we want to improve responsiveness in health systems. And of course, fraud actually has a massive, the losses that we have from fraud and corruption in health systems has a massive impact on our ability to meet these health system goals. So I just want to very briefly touch on the different kinds of purchasing arrangements that we're looking at in health systems. The first one, just to differentiate between them. I was asked just to discuss the differences between them. So to start off with, we have procurement. Procurement, as many of you know, is about acquiring goods, medicines, equipment, and inputs in relation to health services. Purchasing, on the other hand, is a more sophisticated way of purchasing services. And it's really about the relationship between the purchaser, who holds the pooled funds, and the health service provider. It's about the allocation of resources from the purchaser to the health service provider. In almost all countries, even low and middle income countries, there is a split. So we do have a purchaser and a provider in the health system, and it's even more explicit in systems where there is an explicit purchaser-provider split. And that's something that I know well from my own experience in New Zealand, I originally started my career in the New Zealand Ministry of Health, where we introduced the use of the funder-provider split. I think it was about 2005. In terms of the difference between the two aspects, so purchasing and procurement are quite closely related. Purchasing tends to be done by the Ministry of Health and National Health Insurance Agency. It involves paying service providers. It involves different payment methods and rates. It involves contracting with public and private providers. Procurement, on the other side, tends to be more about purchasing goods and supplies, determining volumes and the kinds of things that are purchased. And then the other aspect I wanted to really touch on, and it's more an issue in low and middle-income countries that WHO work with, but it's a whole question of out-of-pocket purchasing, where we're seeing people buying services directly through direct payments to providers. And of course, this is something that we want to move away from, because there's no pooling of financial risk. It's uncoordinated. Decision-making is fragmented. It's very inequitable. It excludes those who are unable to pay. It leads to inefficiencies and financial hardship. And so we really want to move more to a pooled system and a system where services are purchased strategically. So where funds are collected and managed collectively through insurers and taxes and insurance, that enables more equitable access to financial protection, and it supports more evidence-based and cost-effective purchasing. It allows us to assign incentives to quality and efficiency, and strengthens progress towards universal health coverage. So we really want to move from this kind of passive purchasing situation where people are paying out of pocket to a more strategic purchasing perspective. And what is strategic purchasing? So strategic purchasing is about linking payments to information on provider performance and health needs of the population. An important aspect of strategic purchasing, of course, is to understand where the corruption risks are in systems and make sure that strategic purchasing systems are designed to ensure that we identify and manage corruption risks. It's all about an evidence-based system to make sure that we define the service mix that a country would like to have in place appropriately and the volume of services, but also to select the provider mix and decide how to purchase services, to manage the expectations of the population, to make effective use of health resources, to focus on quality and quantity metrics, and to avoid funding and incentives. Align funding incentives with the promised services. So it's all about making sure that we're actually managing the system appropriately. And countries in all income levels, from low and middle income countries to high income countries, are trying to move from a passive scheme to a more strategic scheme. So from a passive place where the resource allocation is not strategic, where there's little or no selection of providers, where there are little or no quality monitoring, and effectively governments and patients are price and quality takers, to a more strategic system where payment systems create deliberate incentives for efficiency, equity, and quality, where we can use selective contracting to influence system performance, where we can improve quality and reward better performance, where we can use price and quality and manage costs to, again, improve system performance, and where there's strong governance and coordination across different purchases. And all this is based on information. So it's very critical that we have excellent information to allow us to run purchasing systems appropriately. We need to know how much money is available, how much money has been spent, and whether it has been spent in the right way. We need to generate and use data, clinical, financial, and other data to work out how to allocate funds in future, to make adjustments, and to make sure that providers are behaving in the way that meets the expectations of the government. We need to unify data collection. This is a big agenda in a lot of countries where there isn't a unified data system and where we have big black holes in relation to the data in the health system, particularly around providers that are outside of the direct control of the government, like private providers. And we need to work, I think, a lot more to unify information systems to make them more interoperable. And this is super important, I think, for the anti-corruption agenda too. The more that we can make sure that systems are interoperable, the less chances there are for systems to be gamed and for risks associated with poor data to lead to more leakages of resources in the system. So strategic purchasing involves three core areas. The first is what to buy, the second is from whom to buy, and the third is how to buy. So in terms of what to buy, this is all about specifying the different benefits that the government wants to purchase in relation to its population. So focus on a PHC level, and we heard from my previous speaker, my colleague from the Ministry of Health, about the importance of allocating funds to primary healthcare services. This is definitely one of our key messages at WHO. Making choices about specific treatment options, having choices about medicines, and that all relies on having really good systems to make choices about how you prioritize and allocate resources to priority services and products. It also involves specification of conditions of access to those services, whether that also includes patient cost sharing and referral rules. And it also involves the need for specification of service and standards. And the second aspect I spoke about is selecting providers. So this is incredibly important in the strategic purchasing scheme. We need to be really clear about the levels and types of provider that we want to purchase services from, whether they be public or private. We need to make sure that we're selective when it comes to selecting providers. And we can use contracting and accreditation schemes to make sure that we select from the best providers to achieve our health outcomes. We also need to use selective contracting, though there are some challenges in this area where we have a limited number of providers, say in a rural or a remote area. And we need to make sure that we have really strong systems for monitoring performance. And the third aspect that I was going to talk about is setting coherent incentives. This is really important for the operation of efficient purchasing schemes, making sure that we have the appropriate incentives in place for providers. So we need to make sure that we have an appropriate payment system. The payment system is well designed for the country in question. And that really depends on the health system's objectives and challenges as to what sort of service delivery model and purchasing model is appropriate. Each of these models has its advantages and disadvantages, and we're going to hear more today about how that impacts on aspects of fraud. But it's also generally good to move away from line item budgets. This is WHO's policy advice to countries. Move away from unmanaged fee-for-services to a more strategic purchasing sort of arrangements. And we need to look very carefully at the payment methods and rates, because they're really important, because they can really heavily influence provider behavior. So we want to incentivize things like primary healthcare, and we heard that this is exactly what's happening in Spain. And we want to try and make sure that we have lower prices for those services and not so much emphasis on high-cost services, at least in the public system. And then I just wanted to very briefly go through different payment methods and incentives involved in them. And I think this is quite important for your ongoing discussions today about how these payment methods might be susceptible to more corruption risks. So I just wanted to go through the main payment methods that we work with in our work at WHO. So some countries still use a line item budget for payments. So where providers receive a fixed amount to cover specific inputs. Now, this is not something that we recommend. It's not efficient, and it's very risky from a fraud point of view, because you don't have such a good handle on whether the resources are actually going to the patients or to the places that you want them to go to. The second mode is to have a global budget where providers receive a fixed amount of funds for a certain period to cover aggregate expenditure, and where they have some flexibility around how that budget's used. And this is better. There's potential for more efficiency due to budget flexibility, and for better alignment, but again, there are some risks associated with it. The third method I wanted to talk about is capitation, where providers are paid a fixed amount in advance to provide a specified set of services for each person enrolled for a fixed period of time. And again, this is a slightly better system where we have a greater potential to align resources to service outputs and to have a better enabling environment for care integration. The next method, and we've already touched on this, is fee-for-service, where providers are paid for each individual service. And I mentioned this is not something that we are wanting to encourage. We want to encourage more pooling. We want to encourage more strategic purchasing, where we have, in some ways, it has got some advantages because it does allow for the direct alignment of resources and inputs to service outputs. But if you're thinking about our thinking on corruption, this fee-for-service and out-of-pocket expenditure is an area that's definitely something that WHO has a lot of work on to try and reduce this. We don't want patients to be funding out of pocket. We don't want patients to be turning up to healthcare facilities and being asked to supplement or pay extra for the services that they should be getting for free. So we're trying to encourage a move away from fee-for-service payments. The next type of purchasing that I wanted to talk about was much more of a hospital-based one, and this is where we have case-based or diagnosis-related group charges, where hospitals are paid a fixed amount per admission depending on patient and clinical characteristics. And this is seen as a great advantage because it allows for more alignment between resource inputs and service outputs. And then the last one I wanted to talk about is I don't think it's that common in this region, but where hospitals are paid a fixed amount per day, so that's for patients that are admitted into hospitals, so like a per diem rate. And I just wanted to say that there is no perfect payment method. Each has its strengths and weaknesses, but I think it's fair to say that some of them are more susceptible to fraud and corruption than others. The more we can move to more formal systems, the more we can have better information about the services that are being provided and the way money is expended, the more that we can reduce the risk that the resources will be diverted. I then just wanted to finish by talking a little bit more about the specific work that the WHO does on corruption. For a long time, we didn't do that much work on corruption. It's always been a very difficult topic to talk about. And so I fully appreciate and acknowledge the work that Spain's done to take forward their work on corruption. On the QR code on the screen, if you want to scan it, you can find a link to WHO's Global Network on Anti-Corruption, Transparency and Accountability in Health. So alongside your network, we have a network of UN agencies and NGOs and academic institutions who are working together to try and reduce corruption in healthcare. And I just wanted to highlight a little bit why we're doing this, because we really do realize at WHO that health budget processes are really vulnerable to corruption. So we're looking at corruption prevention across all of our different member states, from low and middle income countries to high income countries. And of course, this is an area of high risk because of the large financial flows, because of the large number of complex transactions in health systems, because of multiple stakeholders and public-private interactions. I think this latter issue, public-private interactions, is perhaps something we need to look at more when it comes to corruption risks. In some countries, there's limited oversight and enforcement when it comes to corruption, and corruption diverts funds from health priorities and reduces access to services. And next year, we're hoping to do a study to try and come up with a figure which looks at the global cost of corruption in health. We're hoping to start that early in the new year. There are some existing estimates, including some work that was done by an esteemed colleague in the audience, Jim G, who's right at the back. So Jim did some work a few years ago with WHO to come up with an estimate of how much we're losing to corruption in health. And we think maybe between 7 and 10% globally of healthcare resources are lost to corruption. But we want to do some more work on that next year. We've also just completed a new study on corruption risks in the public financial management cycle. So we wanted to get a better understanding of the corruption risks in health budget processes, not just in purchasing, but across the whole budget process, the whole budget cycle. And our objective is to be very clear about the manifestations of corruption in health budget processes, highlight common vulnerabilities, risks and drivers, and to develop actionable recommendations for policymakers going forward. I just wanted to close with this. I hope you can see this diagram, just to show where we've mapped out where things can be lost in the public financial management process, not just in the contracting process, but right through the PFM process, from budget formulation, where money can be lost, where money can be diverted into non-health purposes and health purposes, at the budget approval stage, at the budget execution stage, which we'll be talking about during this session, where we can have leakages, diversion, embezzlement, payroll fraud, the big problem of ghost workers that occurs in some countries, procurement corruption, which I guess we'll be talking a lot about over the next couple of days. Data manipulation, really important. Overuse, capture of funds. So if you are interested in learning more about this, I mentioned that we have the Montreux meeting coming up. It's in December. You can participate online, and I'm very happy to provide details of how you can participate if you'd like to. So I want to close there, and thank you for your attention. And I'm not sure if we're doing questions or answers or not, but I'll be guided by the compere.
Thank you very much, Mr. David Clark, World Health Organization team leader in universal health coverage and a lawyer specialized in health law and policy. Unfortunately, there's no perfect financing method, as he has told us. We've learned that every decision counts, what to buy, whom to buy, and how to buy, and it's very important to have all the data with us. I think it's now time for a coffee break. Is that right, Philippe? But before that, please, you have to go and do a family picture, a group picture. So if you could please leave the room for that photo, and then you can enjoy the coffee break. We'll see you around 11, in half an hour, Philippe? 11:15. See you back here. Have a lovely break. Susan. I hope you had a nice break. You stretched your legs and done great networking. We're going to move on to what we call a lightning talk, a short one but very important. As you can see on the screens, it's entitled Compliance by Design, what it means to embed compliance into systems from the start. The aim of this presentation will be to explain the concept of the direct immediate payment and its risks of fraud related to this system. So please, let's roll the red carpet for Laurent Wilms from the Anti-Fraud Office in Luxembourg.
Hello everyone. First that I would like to thank the AHFCN and the Spanish Minister to give CNS the opportunity of sharing the concept of our immediate direct payment. You will notice that in the PowerPoint presentation I choose to keep with the name, the French name, PID, Paiement Immédiat Direct, which was implemented on our side from 2023 on. It is for CNS it represents a paradigm shift to simplify access for all to the full range of healthcare systems. And first of all, I would like to start with the concept in it to see how it works. So you have first, of course, it starts in a very traditional way. The patient consults his doctor and is examined by him. After the consultation, then in presence of the patient, the doctor enters the codes for the treatment he has performed into his practice software. This data is then immediately transmitted to the CNS, who queries its rules engine and returns to the doctor a simulation showing not only the total bill, but also which part is covered by the CNS and how much remains to be paid by the patient. The patient then pays his part and his part only. The payment of the CNS goes directly from the doctor to from the CNS to the doctor, and this transfer is carried out instantaneously. So you notice it's immediate and direct payment. At the end of 2024, we had like 50% of the doctors covered with the PED concept, but there were still some adjustments to be made by some of the software publishers, so that we expect, however, that by the beginning of next year, most of them are all connected to the system. The main advantages, well, I mean, of course, the main advantage of the system is for the patient. The patients, they don't have to pay the medical expenses in advance no longer anymore. And then the PED removes almost all cash flow barriers to access to care. There are efficient, repeat, and secure financial flows. And for us, it's the big advantage that we get immediate data. Well, of course, there is also an aspect of the fraud prevention, which is really important. For example, we have the disappearance of the phenomenon of falsified bills by insured persons, which really was somehow a problem because we had cases going from 10,000 euros to even 100,000 euros, where there were fictitious bills having been created by insured persons. Well, we had one case where there was a dental assistant who had the know-how to really do these bills in a very coherent manner. And then, of course, another big advantage in terms of prevention is that we can take prompt action against healthcare providers because we have a direct impact on their income. Of course, when we say it is immediate and direct, also the money is transferred immediately and directly. So first of all, the insured person, yeah, of course, as a first level of control disappears somehow because let's say if an insured person now goes to the dentist, she's not presented anymore a bill of 150 euro, but she has only to, the person has only to pay her part, the part of, let's say, 18 euro, so the control can be less, with less rigor. Then, of course, when we say it's a direct transfer of money, it is possible that now the fraud goes more from the insured persons to the healthcare providers, to the doctors, with potential consequences as billing for services not provided or overbilling. And I think, therefore, it's really important, and that's the theme of the presentation, to embed compliance into systems from the start on. We have there first, in the next few slides, I will present you the control mechanisms we have in place. There is the first one, which is our rules engine. And the rules engine is there are included all our billing rules which are existing in the nomenclatures. That means accumulation rules, reduction rules that have to be applied by doctors. Another advantage, of course, of the rules engine is that there is no more human factor. It is a strict application of billing rules to all in the same way. Patients are no longer exposed to the risk of paying for something for which they will not be reimbursed. If there is a new phenomenon of incorrect invoicing, as mentioned before, we can take prompt action by blocking certain combinations of acts. And I can give you an example on this. The CNS had noted recently that there was around 20 dentists billing normal scaling, détartrage, the normal scaling, with periodontal scaling. And in the same session, which from a medical point of view makes no sense. So we contacted them, of course, for asking for reimbursement, and we immediately implemented this interdiction or this prohibition of accumulation of codes into our system. Of course, it is never there is never a zero risk. There is never zero risk. There is a remaining risk. The doctor, if the doctor and or the patient does not agree, the doctor can either resubmit a new list of acts performed. So because first of all he gets let's say an error message. No, you cannot bill these codes together. For example, if he does not agree, he can resubmit a claim for reimbursement and then see if this one could work. Or he can choose another alternative mode, which is, for example, the old reimbursement, standard reimbursement. But of course, there we will be very strict, because then the patient will be the one who is getting damaged, because he will not get the reimbursement just because the doctor wanted absolutely his money to have. And then we take immediately contact with the doctor and tell him that this cannot go on like this. Then we have, of course, a second control. As mentioned before, yeah, and somehow the first check of the insured person disappears. But we have, however, they can when they pay the bill, they should get a bill. We see now very often that this is not always the case. You only get the credit card machine, and then you have to put your credit card, and then you pay your participation, and you leave the practice. So this is not how this should go. That's why we have also another mechanism to avoid that the patient, or to inform the patient about what was being billed. That's what I said. That then, or if there is no personal part to pay, he receives a letter from the CNS with details of the services billed by the doctor. That's somehow from the patient a priori and a posteriori control. The delivery of our letter will be made either by e-delivery or by post. That's, for example, you can choose to to get it via delivery, but if you have not chosen for that option, then you have the detail of reimbursement who has been sent to you at home. I took a personal example of mine. Here you can see so that there I was at the doctor. This was my general practitioner. Then this was the code who has been built, and this is the date of the session, how much was been built by the doctor. That is what the CNS takes into account. That is what I should have to pay, and that is the tariff which is agreed by CNS, and this is what the CNS actually pays. So there it is. When I get this information, and if I have paid more than €7.32, I know that there is something maybe not fraudulent, but it's something that is not or incoherent, we would say. So then we have another control mechanism, which is the posterior control. And the posterior control resides in statistical analysis. We have, I think most of you don't have a centralized system. We have the big advantage in Luxembourg that we have the CNS where all the data is centralized, and so we can now, with the data coming immediately to us, carry out very quickly our controls, our statistical analysis, I mean, this is for us a big advantage because we can take action a little bit earlier. For example, we noticed for some general practitioner significant increase in the number of higher rate consultations, and there were only 10 of them who really were outliers. And so we asked them to their position, because one of them, you must know there is a difference of €30 per consultation. If you build the higher rated consultation, or if you build the normal consultation. And for one of those general practitioners, we noticed that he had actually in 2023, when you compare the ratio of C38, the higher rate consultation, to the normal consultation, he was in like 0.68%. Then in 2024, he rised up to 43.55%. He got the PD system in 2024, I think it was like summer. And then now in summer 2025, he managed to have more higher rated consultations than normal consultations. So this immediately appeared to us because of the statistical analysis that can be carried out immediately because of the data coming in immediately to us. Then I would like to share, last of all, an example of a success story. Well, I call it a success story, but you can see all the three of the control mechanisms are playing their role into this case. So we had, first of all, we had several patients that have complained to the CNS that the treatment listed on the reimbursement detail did not correspond to the treatment carried out by the dentist. So that is red alert signal. Then the statistical analysis, we did some, and we noticed that this doctor, since he had joined the PED system, his total gross amount invoiced had, for example, increased of 280% for the same month from 1 year to the next. So when he was not into the PED system and when he got into the PED system, with even a top at 645% 1 month compared to the other from 1 year to another. And then the third point was, of course, we carried out a little more research on an investigation on this practice, on this dentist. And we noticed that there were also some problems with his authorization in terms of radio diagnostic, because we noticed that he built a very, very huge amount of radio diagnostic acts, and this was somehow not medically justifiable, and it was not logical at all. It was simply too much. And we got the information that his authorization, there were also some problems, and then we could block easily the reimbursement of radio diagnostic for him. But of course, we noticed him. We notified him that we would from today on block his reimbursements, and so with immediate effect we could block those acts. So you see, the 3 points I pointed out here are all relating to one of the control mechanisms that exist around the PED system in Luxembourg. So, the conclusion was that this case could be referred to the public prosecutor's office more quickly than it would have been normally if we would still be in the logic of the patient advancing their fees and then asking for reimbursements, because that can make up to 2 years before we get the bills for reimbursement. And so it is a very efficient system that helps us also a lot in terms of preventing and fighting fraud. Thank you.
Thank you very much, Mr. Laurent Walms from the Anti-Fraud Office in Luxembourg. We've seen the pros and the cons of the direct immediate payment, where sometimes the doctors are the ones that are corrupt. We know how important the prevention and detection are in avoiding fraud and corruption in healthcare. In Spain, we have a watchdog called El Observatorio, the observatory. And to explain how it works, we have with us Mr. Jacobo Fernández, Technical Secretary of Spain's Ministry of Health.
Good morning to you all, dear members of the EHFCN community, guests, colleagues. It is a great honor to be here today at the 20th conference representing Spain's Ministry of Health and sharing the progress of a project that is very important to us, el Observatorio contra el Fraude y la Corrupción Sanitaria. This observatory was created in May 2024 under the leadership of our minister, who I must emphasize has been deeply committed to integrity and transparency long before taking office. In fact, she actively participated in the meetings of the NET prior to becoming minister, which clearly shows her vision and dedication to these values. Today, I will give you an update on our work. Last year, during the previous assembly, we presented the milestones of the observatory. But this year, I will, and I'm very proud of it, I will focus on the implementation of our strategic plan, the innovative projects we have launched, and the next steps we are preparing for 2026. The observatory is not just an initiative, it is a structural commitment to integrity within the Spanish healthcare system. Its leadership rests with the minister herself, ensuring that fighting fraud and corruption is not a side issue, but a main priority of our health policy. This political backing has allowed us to move forward decisively and to integrate our work into a broader national strategy, such as the Spain's Open Government Plan. Here we have what explains our dynamics, internal dynamics of work. First of all, the role of the Secretary is to design methods, coordinate evaluations, and provide advice to all units of the Ministry. The Observatory is integrated into the Ministry Integrity System, a comprehensive framework designed to prevent, detect, and address risks of fraud and corruption across all areas of healthcare governance in terms of the competence of the General State Administration. This system is directed and led by the Subsecretaría, which is my boss, which ensures coherence and alignment of integrity policies throughout the ministry. It also includes key components such as the anti-fraud plan, risk mapping, whistleblowing channels, and compliance with national and EU standards for transparency and accountability. Furthermore, La Subsecretaría plays an active role as a member of the Observatory plenary, reinforcing its strategic importance and guaranteeing that integrity remains a top priority at the highest level of decision-making. We work also hand in hand, with the Ministry Cabinet, ensuring that every measure we propose aligns with the highest standards of transparency and accountability. Here we have the progress on the strategic plan. Our strategic plan is structured around three main axes: prevention, alerts, and communication. Each axis includes specific measures aimed at reducing risks and strengthening integrity. And of course, and it's one of the things I'm going to talk about right now, the execution goals, milestones set for progress and completion tracking. Which are the examples that I could talk to you right now? Under prevention measures, here you have to simplify procurement processes to reduce risk. We have made analysis of the public sector procurement platform, starting faster and more transparent procedures. We have also contributed to legislative proposals to improve contracting rules for innovative medicines, ensuring that exclusivity rights do not compromise fairness or efficiency. Healthcare managers at hospitals reported difficulties in acquiring medicines under the procedures of our Spanish public sector contracts law, which has led to an excessive and unjustified use of minor contracts. To address this, during the drafting of the preliminary bill on medicines and health products, a proposal was submitted to the Ministry of Finance to amend certain articles of the Spanish contract law provisions and make procurement more efficient in specific cases related to medicine purchases. The proposal includes several key changes: the joint development of a public healthcare procurement guide made with the Ministry of Finance, also an amendment to Article 29.4 allowing gene therapy medicines administered once with effects lasting over 5 years to have contracts extend up to 10 years. Modifications to another provision, 27, to reinforce dynamic procurement systems and introduce special rules for medicines protected by exclusive rights, aiming to streamline and simplify these processes. The proposal has been incorporated into the preliminary bill on medicines. Its final approval will depend on parliamentary proceedings, during which the Secretaría General Técnica and the Directorate General for Common Portfolio, Dirección General de Cartera, will respond to any amendments raised during the legislative process. In the alert axis, we launched a whistleblowing channel for the State Foundation for Health, Childhood and Social Welfare, the FCSAI, which depend on the ministry, fully compliant with the Spanish law 2000 and 2023. This channel guarantees confidentiality and professional handling of reports, building trusts among staff and partners. The whistleblowing channel is a key tool for detecting unlawful conducts, allowing employees and external parties to report irregularities. It is an essential component of compliance and crime prevention programs as established by Law 2023, that, as we all know, it transposed an European directive. This law permits public sector entities with fewer than 50 employees to share their internal reporting system and investigation resources with their parent administration. This foundation, a public sector entity with fewer than 50 employees, is legally allowed to configure its own whistleblowing channel. In March 2024, a consultancy proposed implementing such a channel for this foundation, and the foundation informed its staff about its launch. The communication emphasized professional, impartial, and confidential handling of reports, provide clear usage instructions, and offer the headquarters as a point of contact for additional queries. The foundation channel is accessible via its website. Finally, in communication, we developed a dedicated microsite for the observatory, created an institutional logo, and published a formal declaration of integrity signed by the Minister. These actions are not just symbolic, they are part of a wider effort to make integrity visible and measurable. It is also worth highlighting the comprehensive communication plan approved by the Observatory. This is the plan I present to you, which includes both internal and external communication measures with a special focus on training public employees and fostering a culture of integrity within the Ministry. The communication strategy of the Observatorio aims to ensure that all preventive measures are widely known and understood. Communication is considered a key ally of prevention and is embedded in Axis 3 of the strategic plan. It says, communication and collaboration. The plan emphasizes creating an ethical culture, promoting awareness and training, encouraging staff participation, and fostering leadership commitment at the highest level. To build an ethical culture, El Observatorio will use tools such as a dedicated logo, a microsite regularly updated with relevant content that is also translated into English, and you can see it at the website of the department, and quarterly newsletter. A formal declaration by the Ministry will reinforce the commitment to integrity, complemented by news dissemination through the Ministry intranet and external channels. Additionally, the development of a healthcare ethics code aligned with the Ministry integrity system is under consideration right now. Training and awareness initiatives include specialized courses on fraud prevention, risk management, and case-based learning, as well as targeted sessions for senior officials. Articles in the Ministry bulletin and newsletter will further support these efforts. Staff engagement will be promoted through risk matrix development, whistleblowing channel dissemination, perception service, and focus groups to identify improvements. Leadership involvement will be strengthened through mandatory workshops for directors and senior managers. Overall, the plan seeks to integrate communication as a core component of anti-fraud policies, ensuring transparency, participation, and continuous improvement. By combining internal and external actions, the Observatory aims to create a culture of integrity that permeates all levels of the healthcare system. Our execution targets are ambitious. By the end of 2025, we aim to achieve the 30% of the plan. Next year, we think we are going to accomplish the 75%, and by 2027, the 90%. Full implementation by 2028. Now I'm going to present the Conflict of Interest project, which we are really proud of it. The identification of conflict of interest within the department. One of the most groundbreaking initiatives is the development of a methodology to identify potential conflicts of interest within the Ministry of Health. The project is unique at both national and international levels. The methodology was approved in May 2024 and presented at the Observatory plenary in June 2025. It is based on a detailed analysis of the Ministry organizational structure, identify functions that could pose a risk of conflict. We created structured tables with legal references, functional descriptions, and risk indicators, enabling each unit to reflect on its vulnerabilities and propose mitigation measures. I am proud to say that this work was designed by one of my advisors, Natalia, which is right here, who will present the technical details tomorrow, along with other members of our team. Their dedication has been instrumental in turning this idea into a practical tool for integrity management. We have an evaluation example that is in HESA, and she will show you tomorrow. Let me start this example. In HESA, the National Institute of Health Management is responsible for providing healthcare services in Ceuta and Melilla, two Spanish territories with unique challenges. The evaluation revealed strong compliance with integrity standards, but also highlighted areas for improvement, such as reinforcing transparency in procurement and enhancing training on ethical conduct. These findings are not just theoretical. They are guiding real changes in organizational practices. Looking ahead, we have two main projects that will define the next phases of our work. First, the implementation of the SNCA, the Seneca Risk Matrix, developed by the Spain's General Intervention Board for monitoring the correct use of EU recovery funds. Our goal is to adapt this methodology to all expenditures within the Ministry of Health, creating a comprehensive risk management system tailored to the specific needs of healthcare administrations. Second, we will launch the first edition of the Observatory Integrity Awards, recognizing best practices in transparency and ethics across the healthcare sector. These awards will be open to all public health administrations, hospitals, and agencies, promoting a culture of integrity and inspiring innovation in governance. Dear members of the NET community, guests, it is a daily practice that requires commitment, tools, and collaboration. Through the Observatory, Spain is building a framework that combines political leaderships, technical rigor, and international collaboration. Thank you.
Thank you very much, Mr. Jacobo Fernandez, Technical Secretary of Spain's Ministry of Health. I'm sure those awards will be very inspiring. It's now time for a 30-minute panel discussion on our specific topic. The panel discussion is entitled Design and Development of Healthcare Financing Systems for Compliance. We will hear about different ways of financing healthcare systems and the diverse forms of fraud associated to them. I'm going to be joined by 4 experts, 3 of them who have just come up to the stage, and we want you to ask questions at the end that will, of course, be answered. So if you can please have a look at your conference pack. At the end, you have a code, and if you scan that code, you can send your questions. So let's call our panelist, who will be sitting over here. I'll be sitting in the middle, if that's okay. So let's start by calling David Clark from the World Health Organization, Jacobo Fernandez from the Spanish Ministry of Health, Laurent Wilms from the Anti-Fraud Office in Luxembourg, and we want to add a new voice, Eugène van Mierlo from IKZ, the Netherlands, the Healthcare Fraud Information Hub, and new member too. Hello. Now. So remember, if you want to send questions, you can use the code on the back of the conference pack. Okay, let's crack on with the panel discussion. We will try and be dynamic, so if you think you have to interrupt, please feel free and do so. Design and development of healthcare financing systems for compliance. There you have all the speakers who are here with me. The opening theme is building systems for integrity and resilience. And this is going to be addressed to our new voice, Eugène van Mierlo from IKZ Netherlands. Could you briefly describe the structure of the Dutch healthcare financing system so that we are all familiar with it?
Yeah, actually, I would say, please give me half an hour because it's quite complex, but I will try to do it brief. And that's not easy in our system, and that's also why I wrote it down to stick to my point. Now, we have in the Netherlands, we have a decentralized structure with 4 main laws, and that each regulate a part of our healthcare system. And first of all, we have the Health Insurance Act, and that covers curative care, and it involves 10 national insurers. But we also have the Long-Term Care Act, and that is managed by 31 regional care offices. And next to that, and that's also my specific area, we also have a Social Support Act and a Youth Act. And those acts are both the responsibility of our 342 municipalities in the Netherlands. 342. So when you count that all, you see that hundreds of organizations are funding the healthcare in one way or another in the Netherlands. So that's quite complex. It's a solid system, but the complexity makes governance and also the oversight quite challenging.
That's the word, challenging. I thought in Spain we had challenging situations with 17 regions, but hundreds of organizations sounds even more challenging. What are the common vulnerabilities to fraud, abuse, or corruption in the Dutch system?
Yeah, there are many, because of the many funding streams, there are also many actors, and that's why there are also many vulnerabilities that can appear in many forms. And if it's okay, I can show and I can give a few examples. There is a Dutch saying, when you give me 20 cents, you get 2 euros back. So I can explain lots of examples in the Netherlands, but I will focus on a few because of the time, of course. But I think you know it all. Some healthcare providers, they inflate claims. For example, they bill more than or more expensive care than was actually provided, or even for care that never took place. But there are also other healthcare providers. They manipulate care needs assessments. So they exaggerate how much care a person needs to get a higher budget. But now we are coming to the more, let's say, the examples that worry me a lot. For example, diploma fraud. And that means in our country that many people bought their diplomas on the internet. And so it's a fake one. And sadly, it provides entrance to healthcare providers. So it means that absolutely unauthorized people are paying attention and giving help to, for example, your father, of your mother, of your brother, or your sister, other relatives, whatever. And that's, of course, totally unacceptable, but it happens. And unfortunately, and that's the main issue nowadays, also in my region, we see criminal exploitation. People setting up fake healthcare organizations They use stolen identities. They use vulnerable clients as fronts. For example, in cases in my own city, Almelo, that's a city close to the German border, a healthcare provider, let's say, a care company, that's what it is, turned out to be linked to illegal activities like selling drugs, prostitution, using vulnerable people who are independent on the organization for a living by cutting cannabis plants. There is also a case in which firearms were involved. And
Shocking.
Actually, I can say it's a good reminder that for everyone that healthcare fraud and organized crime are closer than we think.
I've never heard something like this. It's shocking, and it's shocking that it also comes from the Netherlands. Could you briefly tell us what's the role of your organization, the Healthcare Fraud Information Hub?
Our role is to, let's say, to connect dots, the dots between the different authorities that deal with healthcare fraud. We collect and analyze fraud signals from a wide range of partners. Let's say insurers, regulators, municipalities, law enforcement. And what we do is we look for patterns. Are there similar complaints about organizations? Are there similar names? Are there financial flows that link separate cases? We also facilitate secure data sharing under strict privacy and security rules, so that information can move between organizations that otherwise wouldn't be allowed to share directly. And of course, another part of our work is research. We study for trends in healthcare fraud, for emerging risks and mechanisms behind them, so that partners can act not only reactively, but also preventively. And finally, of course, we support collaboration. We bring people together around specific cases of or policy issues, helping them to learn from each other in the Netherlands and to strengthen the system as a whole.
Thank you.
We don't prosecute ourselves. We help. We make others better at doing that, using the information we gain and strengthen.
Thank you, Ojim van Mierlo from the Netherlands. Tough and very difficult job you have. We'll soon be listening to Jacobo and to Laurent Wilms, but let's move on to our next point, which is corruption as a public health challenge. This is addressed to David Clark from the World Health Organization. You've framed corruption in healthcare as a public health problem. Could you explain why and what the implications for system design it has?
The reason I did that was when I started working on corruption at WHO, it was very clear to me that WHO is not a fraud agency, it's a health agency. So we tried to work out how we could find an entry point for us to work on this. And I thought about how public health approaches had been used in the past to deal with very difficult problems. So public health approaches have been used in the past to deal with things like knife crime. They've been used to deal with things like alcohol abuse. So what we wanted to do was to try and think about how that applied in the context of corruption. And I think that framing it as a public health problem also makes it very clear that of the significance of the losses involved. So we're not just talking about losing money, we're actually talking about lost opportunities to provide patients with care. In some cases, patients not getting care at all, patients getting counterfeit medicines, patients turning up to clinics and the health workers aren't there. So for me, it's to frame it as a public health problem focuses on its impact on people, not just on the fiscal issues, but also on the health issues. We did do some work last year to try and scope out what that meant in practice. So when I talked earlier about how we were trying to estimate the cost to health systems of corruption. We also did some work to try and estimate the losses to people in terms of lost lives, in terms of lost days of health, And I think this is a very powerful message in terms of trying to get people to commit to anti-corruption work. I think it's easy to have a conversation about corruption and fraud in a room like this, but when you start to talk to a broader audience, it's much more difficult. So that's one thing I wanted to say. Also, I think by taking it as a public health approach, you can deal with it in a much more systematic way. So a public health approach involves 4 stages. So first of all, the first stage is problem definition. So understanding and getting underneath what the actual issues are which are causing the particular problem which is leading to corruption. It might be somebody gaming the system, as we've heard this morning, and stealing money. It might be somebody not turning up to work. It might be somebody asking for money under the table. So we need to get behind why those things are happening. So that's the first aspect of this.
Very diverse forms of fraud,
Yes.
in fact, yes.
Yeah, and then we can start to look at the risk and prevention and protective factors. Because I think it's not just enough to, and this is the theme of the conference, I think, not just to look at addressing these problems after they've happened, but I think it's about anti-corruption by design. And it was really nice to hear the presentation from the colleague from Luxembourg and how they're designing anti-corruption mechanisms into their payment systems. For me, that's super important, and that's a critical aspect of a public health approach. It's about prevention. And the next thing I wanted to, I know we haven't got much time.
I was going to ask you about the Lancet Global Health Commission. Is that okay?
Yes. Yeah,
okay, because you've recently been involved in that commission on anti-corruption in health, which calls for tackling corruption in health as a systemic issue. Could you briefly explain what this commission aims to achieve?
Many different things. I've got some of my co-commissioners up in the back there. So I think we want to really get to grips with what corruption is. I understand there was quite a good conversation yesterday amongst some of the delegates about what they meant by corruption, and there isn't a consensus. So I think there's a lot of work to be done to explain what corruption is and what it means in different contexts. And if you can't do that, you can't really get to grips with solutions. The Commission is also going to look at many different aspects of corruption, so it's really interesting to be here so we can hear a little bit more about the experiences of the people in the audience. We're interested also in finding solutions. So if you look at the literature on anti-corruption in health, when it comes to solutions, it's very sparse. So we want to try and come up with some practical things that we can recommend to countries to actually make a difference. We don't want to say there's this big problem called corruption. We want to say there's this big problem called corruption, and here are some of the things that we can do about it. So it's really great to hear from colleagues who are coming up with new solutions. And the other thing is we want the Commission to be for everybody. So often there's a bit of a pressure to look at corruption as an issue in the developing world. And I think we're hearing today that it's an issue everywhere, and it's an issue in the developed world as well.
That's what we're
we really
seeing.
Want to get that message across as well.
Well, thank you very much. We'll be looking forward to listening to those solutions. Thank you very much, David Clark. Now we're going to move on to the third matter, that is system development in decentralized structures. So I'm going to pass the microphone on to Jacobo Fernandez from Spain, where we have, as I've said before, 17 different regions with their own health service. How does the Ministry, Mr. Fernandez, of Health support the development of integrity-focused systems in collaboration with the regions?
Well, I must say that we have a board that integrates the ministry and the 17 autonomous communities and the autonomous cities of Ceuta and Melilla, trying to pass all the strategies, plans, and the laws, the drafts, the bills that after that will go into Parliament. That prevents any I must say, risk conditions of maybe not fraud, but not being really coordinated the public authorities. But the autonomous communities, as a concept, is like federal states, and they are they have the plain autonomy to make their policies.
So at a state level, if we have to, for instance, look to Ceuta and Melilla, which are managed directly by the state, we have our public contract law that it also applies for autonomous communities, and we have our intervention board that should check previously every contract or every execution of our federal budget, okay? And our legal service also checking all these things, no? These acts of the public administration. And the autonomous communities, in their own rules and policies, they have their own systems. Of course, they have to accomplish our national public contract law and the budget law, the Ley General Presupuestaria. But they are autonomous in the way they will manage these things. But we have, I think we have the same, more or less the same problem. We have the rules, we have the tools also, but we still have corruption in the health sector. So maybe it's more or less to prevent two things. Civil servants or politicians that really have the intention to, to make or to commit a crime in terms of public corruption. Or, in the other hand, I talked before, the civil servants or political representatives that in order to accomplish their goals in the health sector, they have this, this urgency to serve the population, the health of the population, and sometimes they play with the legislation to move forward, not with an intention of commit a crime, but to reach the goals to assist the population. For instance, the excessive use of the minor contracts, that in the end usually is like it's the born of corruption in the end. Okay, these are the examples. Maybe when you have the intention, and in the other hand, when you don't have the intention, but you have to reach some goals, and you have too many efforts in that way. And of course, sometimes this coordination into the administrations have some intersection. I mean, sometimes the state gives funds, give money to the autonomous community, so we have two steps that should be surveilled also. And the state should ask for the autonomous community how they are accomplished, I mean, the accountability of the money, of the funds we are giving them. And sometimes it's more or less coordinated, but other times it is not. No? So we are still improving.
In the Netherlands, you also have a similar decentralized system. I'll pass you mine. How does this complexity, influence your ability to detect and prevent fraud?
Yeah, the biggest challenge is fragmented information. Each organization that we have only sees a small part of the picture. And let's say a municipality, they might see social care payments, an insurer sees medical claims, but no one sees the full pattern. And that's why... and that's why we as an information hub try to do so, to try to get the bigger picture. And next to that, there's also legislation. Privacy and domain-specific laws make it difficult to combine data across sectors, even when everybody's intention is good. And finally, there are also, let's say, diverging priorities. What's a high-risk case for one authority may not even appear on the radar of another one. So that's exactly why the Information Hub in the Netherlands was created, to connect the dots and build a shared picture across all these layers.
Unfortunately, just the fact of having all the information, which is pivotal. Sometimes it's so difficult in these situations. We're going to move to another matter, which is cross-institutional collaboration. So, compliance by design in practice. You, Laurent Wilms from Luxembourg, you introduced the PID, which is Payment Immédiat Direct, which has a problem with the false billing, for example. And what effects have you observed in terms of preventing fraud and strengthening system integrity?
Well, yes, I would like to spot out 3 points in that subject, which are the two first. They are relating to the rules engine, and the rules engine who plays a big role in terms of prevention. First of all, of course, in the interest of the patient, because it allows and it guarantees every patient to get the same reimbursement regardless of human considerations. Then the second one is regarding to the healthcare providers. If we have, for example, in the example I mentioned with the dentist, where we could see that his authorization was not that valid anymore, we can, or even if we get the notice that someone has been banned of exercising, we can take immediate action and then ban him also in our reimbursement scheme. So if that was already the old logic, if that would be still the old logic, then the patients would have to reimburse, and then they get the information that they will not be reimbursed because he's prohibited from exercising. And then the third point, of course, is the fact that the phenomenon of falsified bills disappears. I mentioned the example of the dental assistant who has really good know-how how to produce those fake bills. But we also had another case which was really interesting. There were two brothers, we called them the MRI brothers, because you cannot get that much of magnetic resonance images than they did. And it was also, they did it for the whole family, so even for the mother. So it was really, really tough for us also to get behind that first. But of course, then we noticed, but this caused also a damage of like 50,000 to 70,000 euro to our organization.
Only by one family in particular in this case?
Yes, but it came out that it was only one of the two brothers. The other one did not even know that he used his identity number.
Absolutely amazing. Thank you very much, Mr. Wilms. Next topic, cross-institutional collaboration. Passing the mic here. Yes. Addressed to Eugene Bamierle from the Netherlands. How does your association IKZ facilitate collaboration between insurers, regulators and law enforcement? What challenges do you face in putting everything together?
Yeah, we do it in different ways. We act as a neutral information hub between all these partners, and when a partner receives a fraud signal, they can share it with us securely. We enrich that signal, checking whether others have similar or extra information about the healthcare provider, and then share it back with the relevant organizations. But what we also do is organizing so-called case tables. All partners involved in a specific fraud case, they meet up and then we coordinate their actions. And beyond that, we also facilitate so-called learning cycle, a monthly working group where partners discuss structural issues, legal barriers, practical improvements, and we come together and we discuss it and try to find a way to make some improvements. And 2 or 3 times a year, it's always a time question, of course, but 2 or 3 times a year we host inspirational sessions, bringing together people from different organizations to share insights and build trust. So, actually collaboration happens at different kind of levels, operational level, policy level, and also cultural levels.
Collaboration is
Yeah.
fundamental. Without collaboration, it would be very difficult to tackle all these problems. I'm now going to ask Mr. Fernandez from Spain's health minister, how do you manage differences in all the regions when implementing anti-corruption and compliance strategies? How do you do it?
What do you mean with implementation?
There are differences, obviously,
Yeah.
within the regions, and from the Ministry of Health in Spain, how do you implement anti-corruption and compliance strategies through so different regions?
I will have to repeat the same that I said before. We don't have a regular tool to oblige the autonomous communities, so we have to put together all
Recommendations?
the ideas, recommendations, of course, and we have the idea of using the Consejo Interterritorial de Salud, the interterritorial board, to show the best practices of some of the regions, trying to the rest of the regions to learn from the others. The state is, of course, coordinating and also learning, because we can use it in Ceuta and Melilla.
But can you...
But
sorry.
the way is just to, I have this anti-corruption plan of the ministry, so if you want autonomous communities, you can copy, or you can copy and paste part of it, or you cannot use it if you want. But we are not in a position to oblige
You
or
can't force them.
Reinforce.
Right, that's the other challenge. We're moving to another topic, engaging providers and patients. This is going to be addressed to Mr. Wilms from Luxembourg. How do incentives and support systems help patients engage in fraud prevention? And have you observed any changes in reporting that suggest these efforts have been effective? Is this useful?
Yes, but first of all, I would like to say that there is no system as a bonus malus, for example, in Luxembourg. But however, we have the impression that our insured people are very concerned by their sense of justice. And by publishing, well, we do publish a lot about the fight against fraud and corruption. And then by publishing, we get the impression that their sense of justice can be triggered. Also, but of course, because they hear all about, the financial situation of the CNS is critical, then they get afraid that they have to pay more contributions, of course. So that's why I think they participate actively. We had, for example, the case I mentioned with the dentist, we had 10 patients spontaneously pointing out some irregularities regarding their bills. And as this dentist only had 80 patients by that moment in 2025, we are in a rate of 12.5% of his patients who signalized some incoherences to us.
Wow, so they feel committed in a natural way.
We have that impression, yes.
I think that's actually very important. We're going to pass the microphone to Eugene. The culture, I think, of the country, of how we act is very important. In the Netherlands, Eugene van Mierlo, is there a role of patients for reporting suspicious activity?
Not directly. The Information Hub doesn't have its own hotline or reporting channel or whatever for patients, but those channels are maintained by our partner organizations, the insurers, the municipalities, the inspectorates. But what's nice to tell is that we did some research on how many reporting channels there are in the Netherlands. And the answer surprised even us. I told you about the 342 municipalities. So that also means that when you count it all together, we have more than 500 different places where people can report fraud or problems in healthcare. And you can say there is a way for everyone to tell what's on their mind. And that's true, but we see it as a part of our mission to make the system simpler and more connected. And Now, I heard about the whistleblowing example from Spain. I think we have quite a similar one. We call it report crime anonymously. It's a number that every citizen can call, and then the back office is so arranged that the right actions will be taken. But I see some similarities, and now that's also an example of the exchange of information and collaboration. So, so not directly a role for patients in our information hub system.
That's something maybe we could think about. At this point, I'm going to ask if there are any questions from the application. I think Mr. Tarinier is telling us that the 5 questions. Can we pass the microphone and you can read them out, for example? Okay. Okay. Thank you very much.
So you already have 5 questions, so thanks a lot. The first question is for Laurent from CNS. You mentioned that one of the cases stood out in the statistics. How did you identify this as fraud instead of something else? And there is another question for you from Perpetual, from Zambia, I suppose. What is the impact of the PED system on patients' waiting time, and how practical is it for large claim volumes of 10,000 or 12,000 per day? And then we have a question from Jim G for all the participants. Can I ask each of the panelists if they think a tougher economic climate has led to a greater focus on reducing the cost of healthcare fraud and corruption? So is there now a window of opportunity? And there is a question for David from WHO. How can WHO promote concretely that compliance gets on the agenda from the beginning when health finding systems are developed? And then there is another question.
Shall we start
with this ones? Okay.
Because I think we've forgotten. It goes too fast. I need you to keep the microphone to remind us the other questions, because we're not going to remember them.
Yeah, but they remember it, I think.
Really?
I tried.
Well, he's not too.
Okay. The first one, I got it totally. So I think at least. So if I understood correctly, the question was, how can we when we see statistical abnormalities or something that is not normal in a statistical way, how can we conclude that it is fraud? We cannot immediately, but it is a sign, a huge sign that there can be something wrong. Of course, you have then to have more factors, and that was what I was explaining also in my presentation with the different control mechanisms. If you have on one side, for example, the statistics, you have on the other side, you do have the patients reporting some fraudulent billing, and then you have also maybe a practitioner. You can confront him, and maybe he's admitting it, but they are never saying that they did it on purpose, but you know it very well. They say it was an error, and excuse me, but this was the reason why. I think that statistic, however, can have a huge impact to get a first impression of something that can be fraud. And you can afterwards you have also the medical control who can call patients and examine them to see if that was built is really has been done.
Okay, I think at this stage Philippe has to remind us the question which was addressed for all. Oh, what's the waiting list like?
Let's say therefore I'm not really a specialist, but I try my best. I think regarding the waiting times, it can help for sure the doctors. I think that now it is maybe for them a quicker way to get their money, so they are less concerned by purchasing patients or running after patients to get their money, to get to unpaid bills being paid. So it can have, however, an administrative positive effect on the doctor's work. but now, but it is also in a very early stage, so it is maybe a little early to see how much exactly it has an impact on the waiting times for the patients. Yeah.
Okay, I think Philip needs to remind us the question for all the panelists. Okay, do you remember which one it was? Who wants to answer?
Pass it to you.
David.
I think that's correct. What I am observing is that countries are trying to respond to the shrinking fiscal space for health by trying to look at more efficiencies, and that includes talking about how they can reduce corruption in health systems. But I think there's another side to this. I was talking to colleagues at morning tea about this. So in many countries, you're seeing the establishment of new health insurance schemes without including in those schemes anti-corruption designs. So I think there's two sides to this coin. I think there are definitely opportunities to talk about this topic more because of fiscal constraint, but I think we also need to make sure that when people are conducting reforms, and that's health insurance reforms is one example. Another example I can think of is we're seeing an acceleration of work on digital health, which is great, but I want to make sure that people are designing anti-corruption measures into digital health systems, because I'm not sure in all cases that they're as well governed as they should be. In sometimes, some not. So I think there's two aspects to that question, and so yes, Jim, I think there's a window of opportunity, but I think it opens up new risks as well, which we need to speak about and work to address.
Do we have time for a closing remark, reflections? No, I was just going to, are we, or maybe not. Let's see what the president says.
Just a shorter lunch break.
Yeah, no, we're nearly going to have our lunch break. Okay, no, just very briefly, I would like to ask all the panelists, if you could change one thing in the health systems to prevent fraud and corruption, what would it be? Let's keep it brief. Let's start with Lauren. I know it's a difficult question, but just one thing.
If you can change one thing...
Or what would you change if you could choose?
Well, of course, that the risk, that there would be a risk zero, but I think that is not possible. So we have to raise awareness. We have to sensibilize our patients, our insured persons, that they get their sense of justice, and so that they really are pointing out something that is not correct, because you have the impression that the relation between a doctor and a patient is very strong, and they are not always how to say, they have not the courage to denounce their doctor, because it's their person of trust.
They respect them. Mr. Jacobo Fernandez, what would you change?
Yeah, one idea is to go to the professionals that manage hospitals. We don't have a really board of civil servants with that experience, and we are trying to put it into a bill that, not at a state level, but also at the autonomous communities, will look for civil servants with experience in managing funds and writing public contracts, etc. Because we have a lack of that experience, and that in the end goes sometimes into corruption. And just one thing, because there was another question, we talked with WHO last year, and with David and his unit, and also the GENACTA, and we are very interested into have the measure of corruption in the health sector in Spain. We don't have the tools, but they have it, and it will have a quite impact, I think, at a media level and into society, to know the percentage
of the impact of corruption in the health sector. So if we have that percentage of the budget, maybe the people will say, okay, we have to do something about this.
We don't have that figure?
No, we don't have it. We have an international, well, David, you can...
Close to 10%, I think.
It's really difficult to come up with a figure at the international level. So we have got a guesstimate that Jim worked on with some colleagues a few years ago. So next year we're planning to redo that work and to try and come up with a figure. But what Jacobo was mentioning is we're also going to produce some toolkits to allow countries to make their own estimates. We're not in the business of trying to say this country is more corrupt than another. What we want to do, though, is to give people information to allow them to work out what the scale of the problem is, where the problem is, and how much it's actually costing the system. And then it's easier for health ministries to discuss this with finance ministries and with other important ministries. They can have a conversation about how important it is to prioritize anti-corruption work.
Well, that, I think, is something that summarized the problem. If we don't even have the figures, that makes us realize how difficult the fight is itself.
Yes.
So thank you very much to all the panelists, David Clark from the World Health Organization, Eugène van Mierlo from IKZ from the Netherlands, Mr. Jacobo Fernandez from Spain's Ministry of Health, and Laurent Wilmes from the Anti-Fraud Office in Luxembourg. Thank you very much. It's time for lunch now. See you at 1:45, is that correct? See you later, enjoy your lunch. Thank you.
Hello, everybody. I hope you had a lovely lunch and did great networking. I'm sure you met really interesting new people. It's time for the case studies of two very important members of the network, UK and France, UK who has recently joined the network, as well as Spain. Let's start with this country, with the UK, who has a similar health system to Spain, but more centralized. We're going to hear about an investigation from the National Health Service who led to an individual who had submitted false invoices for more than £500,000. To tell us all about it, we have with us Ben Harrison, Head of Operations and Engagement at the National Health Counter Fraud Authority.
Thank you. Good afternoon, everyone. As the slide suggests, I'm the Head of Operations and Engagement, currently working for the NHS Counter Fraud Authority based in London. Part of my portfolio is I lead the National Investigation Service, who predominantly do all the primary investigations. This is my first time at this conference. I'm pleased and honoured, and I'll hopefully take you through an interesting, successful prosecution, which is Operation Welsh, a procurement fraud. So I'm sure many of you already know that this slide will just pinpoint what we do, what our functions are and what our objectives are. Just like to concentrate on one of the bullets that we estimate that the NHS is vulnerable to £1.346 billion worth of fraud each year. A phenomenal target, and that's something that we're pushing to improve and remove. So, and the last bullet point just reiterates what my team do. So the NIS team investigates allegations of serious or complex fraud and allegations of bribery or corruption with and against the NHS. So Operation Welsh, that involves Thomas Elric, who's on the screen here. And Elric was the Deputy Managing Director of NHS Harrow Clinical Commissioning Group. And Harrow is based in outer London, which is important for later. He was employed as a contractor, and his role was to approve invoices up to the amount of £50,000. So Elric used a company called Vesuvius to progress these invoices, which were then passed to another company called Tree of Andre Therapy Services. I'll explain the significance of those organisations in the next few slides. So using this supply chain, Elric had authorised payments to this company totalling over £560,000. So a substantial amount of money, and this shows that this was not checked as part of the NHS processes. Just to give some sort of picture to this, this amounts to approximately 20 full-time nurses or one entry-level MRI machine. So that's money that's been diverted away from vital NHS funds. During the course of our investigation, we didn't find any services provided by either Vesuvius or Tree of Andre. So therefore, our claim are completely fictitious and fraudulent companies. The last point comes up in some of our media coverage. So to further validate these invoices, Elric used his deceased wife's email address to sort of further cement those, because when she was alive, she was a general practitioner within the UK. So he was hoping that would add some credibility to these cases. So once the case was adopted by my team, go through all the further inquiries which are highlighted here. So we established that Tree of Andre was registered to an individual called Colin Clark, and it was registered to Colin Clark's father's address in Dunfermline, being in Scotland. So quite some distance away from Harrow in Greater London. This company was started in August 2018, and this is when we suspect that the fraudulent activity started, and we allege that this company was created purely to facilitate this fraud. Through financial inquiries, it was identified that all invoices paid and approved were paid directly into Elric's bank account. So he was receiving the funds directly from this fraudulent activity. Clark and Elric were in a relationship and lived together, and again, both lived in Dunfermline. And some of the inquiries showed that previous addresses for these companies related to Clark and Elric's home addresses. So there's the association for the fraudulent activity again. In total, there were 35 invoices which were approved via this method as part of this procurement fraud and paid again via this method. So it's a process that went on for quite some time and clearly wasn't checked. The last point is really key, just to show what goes into this type of investigation. So it takes up skills, it takes up resource, and many, many diverse skill sets are required in this area. In the Counter-Fraud Authority, we're lucky to have direct access to our team of financial investigators who have access to bank and financial statements, alongside our digital forensics unit as well, who can analyse computers and look for the data and the digital aspect. And also we had support from the Trust in securing evidence via witness statements to further support this case. Again, far more inquiries. This was a lengthy investigation. A very simple check established that there was no website for Tria Vondre. You would expect that for someone providing therapy services to the NHS. It also wasn't registered with the Care Quality Commission. That is something that is part of the sort of due diligence checks and would be expected of such a provision. Also, in England, we have the Companies House Register, and this company was listed as dormant, another key part within this case. Therefore, it hadn't recorded any transactions in the last couple of years. So Clark and Elric were both directors of Vesuvius, and they shared both the same address as the Tria Vondre company. As I said, Harrow is based in Greater London, Outer London, and Dunfermline in Scotland, so it's 330 miles away. So that makes it very, very difficult for them to provide a direct therapy service. Again, some of this stuff could have been identified through due diligence checks. So the big bit for us was on the 26th of November 2021, we made a decision to go and arrest both of these individuals at their home address. Again, lots of logistics to get a team based in England up to Scotland. Because of the differences in legislation between Scotland and England, we needed to transfer them from Dunfermline to Carlisle, which is the nearest English police station on the border, to get them into the English sort of legal and judicial system. That involved transporting two arrested people 120 miles, which comes with its own challenges around risk assessments, etc. So this is all a complex piece of work that requires robust and timely planning. Once they get into the English system at Carlisle Police Station, we can then use our police and criminal evidence powers and get them into that court system and progress, as we did. So my team are all trained and experienced investigators who are trained to do interviews under caution, and interviewed both Clark and Elric immediately after arrests. Clark denied all knowledge of these organisations and these companies, and he stated that he was the director of Vesuvius, but purely in name alone. When Elric was interviewed, he further supported that and said Clark had nothing to do with this, and basically made full admissions himself. He admitted to wanting to live an improved lifestyle, and he said it became an addiction. A really interesting point was, as part of our case that we submit to our prosecuting body, the Crown Prosecution Service, we were requested to submit a detailed financial analysis of Elric's expenditure, and it clearly showed that he lived well above his means. Just to highlight that in an 18-month period, he spent over £215,000 on holidays. He had a couple of dogs, and just to further support that, he spent £50,000 just in kennels. So that just shows the amount of money he was taking, and I would say living way above his means. Due to the results of the interviews, a decision was made to take no further action against Clark and concentrate purely on Elric due to the full admissions made. So he made his first appearance at the Magistrates' Court and entered a guilty plea in relation to fraud by abuse of position. Following that, a decision was made by the court system to sentence him to 3 years and 8 months in prison as well. Quite often, sometimes we don't receive such results because of prison space, etc., but this was a fantastic result. Lots of delays, often due to Mr. Elric in getting to court, but we overcame them. And then a Proceeds of Crime Act process was initiated to look to recover those funds purely for the NHS. And come on to that part. So, in relation to the Proceeds of Crime hearing, a Section 18 notice was served on Elric. That gives him as an individual a duty to disclose his financial position, what assets he has, etc. Very similar to the sentencing, defence provided sort of many delays to try and delay that process, etc., which is a common tactic used in the criminal enterprise. Elric again was asked to provide valuations of assets and properties and falsifies those valuations to undervalue his property. We finally reached real valuations, and the agreement was made at just under £180,000. In June of this year, Elric was ordered to repay £175,000, and the parties, if he doesn't repay that within a certain time period, he's subjected to a further 2-year prison sentence. So therefore, this case is still ongoing, still live, with further financial investigations ongoing. I think a real theme of today's conference has been around lessons learned and how we implement those changes. We share our learning as we go throughout our investigations with the sector, key points via different sort of methods of communication. And the aim is to educate and support the sector and look to prevent such fraudulent activity from happening, and also so trusts within the NHS can identify this early and look to put in preventative action and measures by either stopping this or reporting it to the relevant authorities. So this type of activity really supports our drive for both prevention and deterrence, again, key themes that we've heard about already today. And we look to drive changes in policy and our approaches as well, so this doesn't happen again. You would have seen some of the processes there, the identification. We share that with the trust and the sector to hope that they implement that so stuff like this doesn't happen again. So, as part of our deterrence approach, we have a comms team who work very closely with media. And as you'll see there, some aspects that are shared on the screen to show the range of coverage that we got for this investigation. So, Daily Mail and the Daily Mirror, big pieces of media within the UK. So that's really great coverage. And I said earlier about using his dead wife's email account. That's something that the press really relied on to just try and hit that sort of public attention. We also use social media platforms just to get that messaging out for a wider deterrence piece. This shows the coverage, not just in England, but Scotland as well. And in recent cases, we've received coverage as far away as Zimbabwe, so we feel it's far-reaching, and our media strategy is working very well. I've rattled through that. I appreciate there probably isn't time for questions, but I'm here. If anyone wants any questions about this investigation or anything else that we do in the Counter Fraud Authority, feel free to come and grab me at any point. Thank you very much.
Thank you very much, Mr. Harrison, Head of Operations and Engagement at the National Health Service Counter Fraud Authority. I hope the NHS doesn't have more cases like this, but may I say, as a journalist, those headlines of those stories are very important because it's the way to tell the public what's happening. Now it's turn for France, c'est le tour de la France, a country that has faced new forms of organised healthcare fraud involving professional fraudsters and large-scale financial diversion. With this presentation, we will learn key lessons and insights to help anticipate and tackle future ways of fraud. Let's welcome Marc Scholler, who is here, Financial Director at the French National Health Insurance Fund.
So, hi everyone, let me thank you for having the opportunity to speak after an English native speaker. It will be easy for me to continue. So my name is Marc and I'm a Director of Audit, Finance and Anti-Fraud at the CNAM, which is the Health Insurance Fund. Let me start with a quick overview of the French health insurance system. It is one of the largest public spending programs in France, around 256 billion in 2024, which represents about 12% of our GDP, which is quite bigger than most of the other European countries. It's a solidarity-based system, meaning that the healthcare is funded collectively and accessible to all, regardless of income or area of living. And around 80% of all healthcare expenses are covered by the public system, with the rest share between private insurers, about 12%, and households for 8%. The system is very centralized. It is managed by the CNAM, which oversees a network of 100 local funds, covering approximately 85% of the population, that is to say more than 68 million inhabitants. So we see the whole picture in our system, which is quite different from other organizations in Europe. which is a force, but also vulnerability. Every day, about 400,000 healthcare professionals send digital claims directly to the CNAM for reimbursement. And this infrastructure combines speed, trust, and scales. That's both our greatest strength and, as you will see, a potential vulnerability. In short, it's a system that perfectly embodies social protection at scale, but whose openness and automation have made it an attractive target for fraud. So let's move from the system itself to what makes it both efficient and fragile. The French system is built, as I said, on speed, simplicity, and trust. Patients rarely pay upfront, which prevents treatment dropout and ensures access to care for everyone. But the process is mainly digital. It means that once the healthcare professional sends the invoice, the system automatically reimburses it within a few days after rules engine computes data and conformity. It's quite the same at what Luxembourg presented, but we have it for longer years, and so we have a past of fraud because that's what we call a fast payment cycle. It's very efficient, it's very reliable, and key to our quality of service. To have an idea, we pay in approximately 4 or 5 days. But these strengths also come with a risk because payments are so automated that most smart controls, integrated controls, occur after reimbursement, meaning that we are dealing with a reactive control model. Automation creates exposures, and trust can be exploited by organized actors. In short, the same features that make the French system highly efficient also make it attractive to frauders. So we built a system to pay fast and fairly, but fraudsters learned how to make it pay against us. And that became clear after 2020, which is an important turning point. Since 2020, we have seen a sharp rise in both the scale and sophistication of fraud. What used to be isolated misconduct by individuals has evolved into organized schemes, sometimes backed by corporate or financial investors. The acceleration of digital billing and the context of budgetary tension, which I think we share, has amplified both opportunities and exposure. Fraud became faster, more technical, and sometimes even international. Meanwhile, our former anti-fraud model was very reactive, fragmented, slow, and focused on post-payment controls. We needed to shift from reaction to anticipation, that is to say, to prevent rather than to repair, but prevention alone is not enough. Fraudster takes risk because the reward is high and the sanction is too slow. So our goal has been to reverse that equation, to make fraud immediately risky, costly, and unprofitable. That means faster sanctions, stronger penalties, and closer coordination with prosecutors. It's not only about detecting fraud, it's about making fraud no longer worth it, a kind of losing game. To meet that challenge, we needed a simple and powerful strategy that we implemented 3 years ago. Our challenge was twofold. Protect efficiency by ensuring that every euro spent goes to the legitimate care, and restore integrity by strengthening trust in how public money is used. To achieve this, we built an anti-fraud strategy structured around 4 complementary pillars: evaluate, prevent, detect, and sanction. It's a simple framework, and that may be precisely its strength because it can be easily deployed across all levels of our structure, from national to local, and its aim is to be not technocratic, to be operational, measurable, and collective. So evaluate is the goal of the evaluation is to assume figures that fraud exists, because in the public debate in France, there are a lot of fantasy about the figures behind the frauds, and we wanted to assume the fact that we needed to experiment a certain scientific démarche to evaluate what was the cost of the fraud, so approximately between 2 and 3 billion euros, and mapping and estimating vulnerabilities as fast as possible because fraud evolves and change very frequently, so we need to be very accurate on the evolution of fraud. And moreover, you can't prevent what you don't understand, so prevention is important, but evaluation comes first. Prevention is to embedding fraud control into governance and shifting from ex post correction to ex ante anticipation. This means that everybody needs to have a counter-fraud, an anti-fraud culture, and it's not only the end of the frame that tackles the problem. Detect through data analytics, AI tools, which we experiment, and I think we'll talk about it later in the panel discussion, and strengthen investigative teams, because human is very important, and the power that are granted to people who investigate on fraud are very, very significant. And sanction, because deterrence matters. As we have seen with the NHS, it's important to sanction faster, clearer, and to be more consistent, and to communicate, obviously, about it. So the goal is simple: to make fraud harder to commit, faster to catch, and costlier to attempt. And it's not, as I said, a bureaucratic plan, it's a cultural shift. This change is already producing concrete results, well, not sufficient enough, but a big increase in what we detected and stopped. For example, in 2024, it was a record year for French national insurance. We detected and stopped 628 million in fraud, including 263 million in losses that were prevented before payments. But the key isn't only the amount, it is the transformation behind it. We move from fragmented local actions to national and data-driven system capable of more targeting high-risk patterns. And what maybe, and I hope not for you, but we discussed it at lunch with Luxembourg, there has been a big shift between what was fraud before. It was a fraud of insured people, and now it is a fraud of health insurance, health professional, because around 70% of cases involve healthcare professionals, not only because they are the enemy, but because they are the core of the billing process, where vulnerabilities concentrate. So typical scheme, but it is the same in every country, I assume, include fictitious or inflated billing, fake prescription, identity theft, or misuse of what we call third-party payment, which is the fact that the beneficiaries doesn't have to, there is no out-of-pocket money. So what has changed is our capacity to act earlier and faster to block payment before they leave the system. So let's now look at the most emblematic cases that shaped our approach those last 2 years. So two major frauds we have faced in healthcare centers and audiology share 6 key traits. First, the post-COVID surge. We assume that money has been flowing during COVID, and it has broken a barrier regarding the cash amount that could be diverted from the system. The second is external infiltration, which means that non-medical actors, entrepreneurs, financial, fake diplomas, even criminal networks, analyzing the system and plugged into it. Third, a systematic breach, exploiting automation and zero out-of-pocket payments to create industrial-scale fraud. Fourth, data exploitation with stolen identifiers, which are sometimes sold on the dark web and which can be easily reused. Fifth, professionalization. We see structured teams with high skills and that can fly easily under the radar. And finally, corporate concentration, since some health sectors are shifting focus from care quality to public money capture. So in short, these are not petty scams, they are industrial fraud that fundamentally change the scale of the threat for us. So before describing the fraud, let me explain what a healthcare center is for us. In France, the centers brings together doctors, dentists, specialists under one structure. The model was created to improve access and coordination and it expanded rapidly in the 2010s when non-medical investors were allowed to open them, so there's nothing to see with the medical sector. So that attracted new players, sometimes purely financial, looking for quick profitability. In some cases, medicine became industrialized, acts are or were standardized, productivity maximized, and control minimal. So the fraud followed naturally. The model is to invoice acts never performed or overbilling with wrong tariff. I have a short example that I like. In a dentist health center, we had a patient that did get a dental cleaning, which cost approximately in France 40 euros. And 2 days after, he checked how much it costed to the French health insurance, and he saw that he was billed 2 dental implants for 8,000 euros. So you see the multiplication of the cost. And in a third-party payment system with no out-of-pocket money, the attentiveness of the patients is very low. So if he didn't check by himself, he wouldn't have seen, and we would have taken time to see this kind of fraud. The target is the full coverage patients who pay nothing upfront, so they don't check their bills, which create an invisible billing zone. A financial circuit with a direct reimbursement from the fund to the center, bypassing the patient verification. And the setup is that very often clerks use salaried doctors' identities to send fake invoices, sometimes without the doctor to know it. So the outcome is an industrial-scale fraud with hundreds of thousands of false claims before detection. So a model which is designed to access to care turned into a cash machine. The common pattern of the way we did tackle this fraud combines speed, coordination, and structure. The first is that we need to have medical assessment first. It is very essential to confirm fictitious or overbill acts through doctors and dentists, but which remain scarce resources. Multi-agency coordination, we work jointly with tax authorities, public health services, and police, because fraud don't stop at institutional borders, and neither should we. We created also national task forces, which were created for high-impact cases, which were very often all over the country, which was not the case priorly. So when you have a national fraud, you need to have a national task force to have an important return on investment and to be fast and to align control and legal strategy across all levels. Fast administrative breaks. We have different laws that have been passed in counter fraud, and one that allows us to suspend or delist the center's contract urgently, which is a powerful stop-loss tool that halts billing immediately. That means that we don't give the center any money, so the business plan is completely stopped. And finally, judicial and recovery chains, which ensure escalation to prosecutors and stronger financial recovery. So in short, our response had to be as structured as the fraud itself, which was a good lesson for the second fraud that I will talk about, which intervenes last year, and in a context of a very positive political reform, which was obviously with a good intention. The goal was to improve access to hearing aids for everyone through what we call in French the 100% santé scheme, in which patients could get hearing device with no out-of-pocket payments. And you know that hearing devices are very costly, and a lot of people couldn't afford one. So invoices, once again, were sent for typical specific products directly to the health insurance fund. But the market opened too fast with insufficient front-end controls, and fraudsters moved in with a lot of new companies creating in a very short period of time and with complicity of beneficiaries or using stolen social security data that you can easily find on the web. They build fake devices that were never delivered. Some companies existed only on paper with false diplomas or fake addresses. So the result was a massive billing in a few months, dozens of fake companies and tens of thousands of failed claims. And once again, that was organized and industrial, not a few isolated cheaters. So reform to self-passion became a goldmine for fraudsters because the gates were opened before we had put guards in place. So after the healthcare centers, we were better prepared, but not sufficiently with humility. And when the audiology fraud appeared, we reacted faster. Detection came first by identifying rogue companies who often recently created with massive billing in a short period of time, and red flags show the same patient link to multiple phones, which was the proof of stolen identity lists that were used. Coordination followed with national task forces, mixing analysts, legal expert, investigator, and sharing intelligence very efficiently, and action came quickly with investigator checks, checking if the shops and professionals even existed, and blocking payment, urgently delisting the companies, and sanctioning them, which was very important. In terms of figures, in 2024, these actions produced 115 million in results, and the two-thirds, which we are proud of that were prevented fraud, which was stopped before the payment. So the difference is that we see that the fraudsters are taking speed. It's really, really, really important because when money flows, especially in that kind of case, it goes abroad very fast. It is transformed in Bitcoin. It goes in money laundering machines, and you don't see it. You have no capacity to take it back, and moreover, it's obviously a problem for public opinion because fraud is considered as intolerable, and the risk zero is, as you may know, not an easy target for us. But it's a problem when this figure additions sums up. So these two cases were not just lessons in fraud, they were lessons in resilience. We are now building and trying to build a system that makes fraud harder to commit, faster to detect, and unprofitable. But obviously it's not an easy scheme. To anticipate first the future schemes, which means embedding early controls into every new reform, even political reform, so which means to have a cultural shift, because sometimes the politics is obviously first, but it goes sometimes too fast to have put the guards in place, using data-driven targeting, because contra fraud is obviously costly, and cooperation with tax, states, and private partners. Leverage experience with reusing of lessons from urgent disaffiliation and judicial cases to prioritize high-impact actions with communication. To embed safeguards in our processes, which means closing structural loopholes and making a billing process more secure, traceable, and transparent. To expand investigative capacity. In France, we have the opportunity since the beginning of the year of the creation of 6 regional judicial units, which combines CNAM experts and former police officers with nationwide reach, which is an important weapon. They also can do cyber action and strengthen the digital vigilance and deterrence, because these investigators now work in open and darknet environments, tracking organized fraud online, which is a new weapon. And sorry for the anniversary break, it's not yet. No. So at the same time, we are trying to simplify a sanction procedure to make fraud immediately risky and unprofitable. The goal is not just financial, it is more to protect trust which is the foundation of every healthcare system.
Merci beaucoup, Monsieur Chollet, Financial Director at the French National Health Insurance Fund, CINAM. Thank you for giving us a bigger picture of fraud associated to fee-for-service payment. I don't know whether the video is ready. I'm looking at Philippe. No? Well, in any case, it is now time for another special break, the anniversary break. So see you all back at 5 to 3. Just checking with the President. Yes? Okay, well, there's going to be a special break, anniversary break. I hope you have a sweet tooth. See you all back at 5 minutes to 3. We're back. I hope you enjoyed the cakes, the anniversary cakes. It's time for our second panel discussion entitled Trends in Counter Fraud and Compliance in Europe. And I'm out of the job here. You're going to be introduced by, the moderator is going to be David Garcia, who's sitting in the middle, head of the Advisory Unit and Technical General Secretariat of Spain's Ministry of Health. And he's going to introduce all our next panelists.
Okay, thank you, Olivia. Good afternoon to everyone. I'm David Garcia, as I said, Olivia. I'm working here in the Health Ministry of Spain. Specifically, I'm working in the Technical General Secretary. I'm sorry because of that. Sometimes the translation of the word, the place that you are working, sometimes is a little bit confusing. But one of my functions is to stay in the Observatorio de Lucha contra el Fraude that Jacobo was talking before. So in this panel is titled Trends in Counter Fraud and Compliance in Europe. And I have to say thank you to the European network to let me moderate this, I think, quite interesting panel discussion. So in this panel discussion, we are joined by different experts of national authorities, European networks, and independent institutions. And I'm going to, first of all, start introducing the different speakers. First of all, Alex Rothwell from the National Health Service Counter-Fraud Authority from the United Kingdom. Sofia Viñallo, Deputy Director of the National Service of Anti-Fraud Coordination. Apart that the things that all the speakers they are going to say, I want to explain just a little bit that this institution, the Seneca, is the core of the fight against fraud in Spain. Fraud in general, not just fraud in the healthcare system, but in general is one of the most important institutions. Then, on my left, Olga Escribano from the Independent Office of Regulation and Supervision of Procurement. As you can imagine, we will be talking during this, this session about the importance of fight against fraud in the procurement process. So one of the functions of this organization is this, okay, study and supervise the procurement. Then Manuel Villoria. Manuel Villoria is the president of the Independent Whistleblower Protection Authority that is recently created a couple of months ago, and we have talked about the importance of the whistleblowers in the fight against fraud. Well, he will talk to us about these things, this importance. And finally, Marc Scholler, that is the financial director of the CNAM from France. Thank you for coming. And I'm going to start with Alex. I'm going to make some questions and they will answer about that. And then finally, if you want, we can share different questions, different comments, as you have been done along the day with this app that Philippe, then if there are questions, Philippe will read me the questions to the members of the panel, okay? So first of all, Alex, according to your experience, because I mean, you have a huge experience about fighting against fraud in the United Kingdom. So what are the most pressing fraud risks currently facing public healthcare system in Europe? And how is the United Kingdom addressing them through the counter-fraud strategies?
Well, firstly, thank you, David, for inviting us here. It's a real pleasure to be here in Madrid, a fantastic city. So, look, we've been measuring fraud loss in the UK for about 10 years now. And we know that fraud against individuals, against businesses, is around about the 40% mark of all crime. It is the most prevalent crime in the UK. We've been measuring fraud against the public sector for a similar length of time. Strangely, in the UK, we don't actually record fraud against the NHS or the public sector as a crime. If we did, I think that 40% figure would be significantly higher. It's pretty well, most crime in the UK now is fraud, I would argue. But we think that fraud against the public sector is around about 0.5 to 5% of loss. Now, we're in a good position in the National Health Service because we measure and assess annually what our threats from fraud looks like, so what we think is happening. We measure the financial vulnerability, the loss that we think occurs, and we also assess the risk of those frauds. It's not all hyper accurate. In the areas where we do loss measurement exercises, then we've got a really good sense of what's being lost. In other areas, we have to make more of an educated guess, really. We estimate we lose about 1.3 billion pounds a year in the National Health Service in England to fraud, but that's actually less than 1% of the budget. What we're increasingly finding, though, as we start to use data analytics and do much more detailed loss measurement, that we think, if I'm honest with you, that some of our projections are probably much lower than we perhaps thought they were. So this is something that will emerge. By and large, our highest areas of risk is in procurement. You won't be surprised. We have a big hospital building program that is currently underway, but we also buy a lot of things to deliver our free at the point of service healthcare. Following on from that, we have patient exemptions. So although the service is free, some patients are required to pay, and we see a lot of loss through people misdeclaring their exemptions. One category which, I'm talking about thematic areas here. One category which we're increasingly focusing on is something we call data manipulation. And this can play out in two different ways. One is the incentives that are provided to hospital services to deliver or meet certain objectives. That might be to reduce waiting times, or it might be to see so many patients for a particular type of service, which attracts financial rewards from the government. This is something we're starting to explore. But also, we're seeing more granular examples of claims, as we've seen many examples of today, which have been manipulated in some way to attract higher fees. So lots of, another area where we get a lot of reporting is in staff fraud insider threat. We have 1.7 million employees in the National Health Service, and by far and away our reporting lines, that is the most prevalent issue that's reported to us. Ben gave a good example of a very serious insider risk earlier. I could probably talk about this for half an hour. I know you want to move on, but you asked what sort of strategies do we have to deal with it. Look, right now, funny enough, Mark, our strategy looks quite similar to yours. It's we've got 4 pillars, and we look to assure and prevent and detect and respond to fraud. We have a counter-fraud profession, well, let me put it like this. If you wanted to hire an accountant, you would want to know that they had a qualification as an accountant and could record your finances correctly. It's been difficult to say the same about fraud. What is a fraud professional? What sort of qualifications do they have? So we've created a government counter-fraud profession which professionalizes the work that we do in different categories: intelligence, risk assessment, investigation, and so on. So that's our current strategy. What we're really looking towards at the moment in the future is, I think my personal view is that we need to be much more aligned to healthcare objectives, be able to demonstrate to ministers and those that fund our publicly funded services that not only are we tackling fraud and loss reduction, but how that contributes to our healthcare objectives. And in the UK, we're very focused on digital transformation. We're very focused on moving care away from a hospital setting into the community. And we're very focused on moving away from just treating illness and preventing it. And we can contribute as fraud specialists to all of those areas. So shall I pause there, David?
Okay, so you are planning to do many things in order to fight against fraud. And in your case, I think that you have more power than some kind of institutions in order to fight against fraud, make some investigations. So I think that is the most important difference between the British system and, for example, the Spanish one, that maybe we have shared all those
I think so.
competencies shared in different institutions.
I mean, just if I can give one final example, which is very current, in our parliament 2 days ago, a piece of legislation is going through which should be enacted in the next year or so, which will enable public sector bodies to recover loss from fraud from individuals who have defrauded the public sector. But rather than pursue that through a criminal court, we'll be able to recover that through, for example, taxation or through a reduction in benefits if people can be proved on a balance of probabilities to have committed fraud. That's quite an important piece of legislation for us in the UK.
Okay, thank you so much. Right now, if you don't mind, we are going to continue with Sofia. Okay, so in your case, from your role, as I told you, you are you have the role of the coordination of all the investigations against fraud. That, as I said to Alex, you are one of the institutions more important in the fight against fraud. So, from your role in coordinating anti-fraud efforts, what, at the national level, of course, what trends are you observing in fraud schemes targeting public funds, and how is Spain adapting its compliance frameworks to respond?
Okay. Good afternoon, everyone. And thank you very much to the Ministry of Health and the organizers of this conference for inviting us to be here and have the opportunity to discuss in this panel. My unit, the National Anti-Fraud Coordination Service, is the body for the coordination with OLAF, as well as other functions that we have. For example, we have an external reporting channel to receive reports on suspicions of fraud, corruption, or other illegal activities regarding the European funds. So our field is the protection of the financial interests of the European Union. About the question you asked me, can you hear me? No. Yes. Okay. Can you hear, about the question you asked me, the trends in fraud that we can see in our unit, I could say that the trends are the usual ones in the management of public funds. For example, in public procurement, artificial splitting of contracts, manipulation of procedures, unjustified modification of contracts, collusion, other kind of situations that are fraud in public aids, conflict of interest, which is increasingly more frequent, and document falsification, for example, cost overruns, inflated invoices, among others. So we don't have much experience in the healthcare sector. If I remember right, I think we received a couple of reports about fraud in public aids for healthcare materials. But according to information that we have, for example, according to OECD, the healthcare sector is one of the most at risk of fraud in public aids. And also, there are several rates regarding the public procurement because of different reasons. The high number of contracts and the large amount of the contracts, also the outsourcing of the services and the privatization of the sector. No? That's one of them. In our opinion, in recent years, Spain has made significant progress in the areas of integrity and fight against fraud and corruption, through the approval of several measures, for example, the approval of the integrity system of the General State Administration, that regulates the transparency and integrity of the public employees and officials, senior officials as well. The approval of the law on the protection of whistleblowers and the creation of the authority for the protection, whose president is here with us. The recent approval of the state plan to combat corruption by the government in August this year, and also several draft laws that we have now. We have now one on open government, a draft law on open government and open administration, sorry. And it's been drafting also the law for the implementation of this state plan to combat corruption. Regarding the fraud in European funds, the area of our activity, Spain has introduced as well significant measures, mainly in the framework of the Recovery, Transformation and Resilience Plan that represent, in our opinion, a major advances in the field of the fight against fraud and corruption. For example, the different entities executing and managing this recovery plan are obliged to have anti-fraud plans with different measures across the whole anti-fraud cycle. For example, they had to create anti-fraud committees, internal control units, codes of conduct, ethics codes. The risk assessment is a mandatory activity for all of them. Also the use of the red flags. The introduction, for example, and reinforcements of procedures for prevention and correction of the conflict of interest. So, in our opinion, these measures introduced for the recovery, transformation and resilience plans constitute a starting point for extending this measure to the management of other funds, not only European funds, but also national funds. That's all.
Yeah, I totally agree with you that maybe these funds, these aids for the Resilience and Recuperation Plan, have supposed an inflection point of no return, in order to assume that it's part of our culture in order to the manage of the public funds. It's the first time that maybe one of the civil servants that we are here in this department hear the word map of risks, conflict of interest. Before, maybe we wasn't really aware about those terms. Maybe it's part of us right now. It's part of our culture of workflow. That maybe is the most important thing. So, okay, yeah, thank you for your answer. Yeah, and well, as you see, so Olga, as you see, we are talking about procurement all the time. So, and that you can imagine is one of the most important areas. So in your organization, you are really aware that it's a high-risk area, and I think that you have prepared a presentation about the map of risk. So here you have to control the presentation, if you feel. Okay, give me.
Well, first of all, thank you for the invitation to this prestigious event. It's a pleasure to be here. As David said before, well, I represent OIRESCON, is the Independent Office for the Regulation and Supervision of Public Procurement. This office was created by Article 83 of European Directive 2014/24 that states that member states should create authorities, bodies that supervise public procurement. Afterwards, Spanish public procurement law created the OIRESCON by Article 332, and it defines like a collegiate body that should make this supervision of the public procurement. Especially, it says that the purpose is to ensure the correct application of legislation and to promote competition and combat illegal practices in relation to public procurement. So, related to the question David said about measures that we are applying to combat corruption in public procurement, we developed at the end of 2024 the risk map. I have prepared a little presentation because I thought it was easier for you to follow all the risks that we have detected. I'm going to use the glasses, otherwise I can't see anything. Well, why it's important to prepare a map risk in public procurement? Because it's a really risk area for the corruption. Why? Because public procurement significantly influences in the budget of every country. A lot of money is expended to buy objects, to provide services to the public, and this involves a lot of money. So billions of euros are used in public procurement. So it's easy for corruption to be inserted in this special area. So let's see some figures. If we go to the Eurostat data, we can see that 10.92% of the gross domestic product is used in public procurement. And if we see the figures in Spain, 24.05% suppose the public spending in public procurement. So it's a lot of money related to the public procurement. So why Oirescon decided to create this map? Because, first of all, we are based on the Article 332 from Spanish law in public procurement, as I said before. And it's also a national, we have a national, we create a special national organization to establish some of the points important in public procurement for Spain in all the levels, in the central administration, in the regional administration, and in the local administration. And one of the points that highlight this document is the importance of fighting against fraud in public procurement. So, how we organize the document for explaining all these risks. We organize the risks based on the annual report in supervision that the office is mandatory to make by the law. So based on all the documents that we have made in the last 6 years, we organize the risk in two main groups. First group is the risks that affect to all the procedure. I mean, the risks that affect in the three phases of a contract, that we call it, cross-cutting risk. And then we analyze the risk based on the three phases of a contract: the preparation phase, the contract tender award phase, and the contract performance phase. So if we start in the cross-cutting risk, we can find the following risk. First of all, data quality challenges. The data on public procurement in Spain, you can find it in platforms. It's a national platforms, regional and local platforms. In these platforms, the data is not always with big quality. And this is important because the quality data made us to take recommendation and make conclusion about public procurement in Spain. So one of the challenges in Spain is to improve data in these platforms. Another problem that we have detected, information consistency problem, is when we see the different platforms, as I said, the central, the regional, and the local, we can find inconsistency in the data. So this is a big problem. Some of our recommendation is to create one source of data, because we think it's easier to avoid mistakes if we have so many platforms. We also find that some of the data are mandatory to public in those platforms, but not always happens. And there is not any mechanism in those platforms to avoid this problem. And we also find that we have regulatory and access limitations, again, because of a lot of platforms that creates a problem in this way. Another risk that we have found in the map risk is related to professionalization. When we study by supervision professionalization in Spain, we have detected that not the 50% of the demand with civil servants is not attended. Less than 50% is attended, so it's a big possibility to improve this area in professionalization. But we also found that it's not a career path designed and defend in Spain for civil servants. We have to think that when you work in public procurement, you have a problem. It's a lot of responsibility, a lot of work, a lot of deadlines, and this is not well prepared in all the positions that the civil servant can occupy. That makes that not a lot of civil servants want to occupy this post. That diminishes the professionalization in this area. Deficient institutional coordination. This is important because we found a poor coordination between courts, anti-fraud bodies, and oversight entities affecting governance efficiency. The lack of an adequate coordination is a problem in public procurement. Collusive practice risks. We also found these risks, and this affects to an important principle in public procurement, which is competence, concurrency. This is be affected when we have these kind of practices. We also found some risks related to corruption and fraud. It's important to highlight the necessity of stronger preventive and corrective controls. Legal uncertainty challenges. Why? Because it's a lot of legal and regulation in public procurement, and that creates a lot of problems in interpretation, and it's difficult for the people that is working on public procurement to know what to do. A strategic procurement limitation. One of the goals of all the directives, European directives from 2014, it was the strategic contracts, because it's important to improve some objectives that could be improved by contracts, like labor, like investigation, environment. The contract will be a really good vehicle to obtain these goals, but in practice it's not happening because it's so difficult to relate these goals with the object of a contract. In-house assignment risk. In Spain, we have detected that sometimes it's an abuse of use of the in-house assignments, because administration goes to a public company instead of to go to a procedure for a contract. So this diminishes the importance of concurrency and the importance of being to have a lot of enterprise participating in tenders. Now we pass to one of the phases of the contract, which is preparation phase. What kind of risk, thank you very much, we can find? First of all, we don't have any document of planning in public procurement. This is important because company needs to know what administration want to contract, when they want to contract, to prepare all the documentation. All the procedure in public procurement is really long and complex. So if it's a planification, it helps to the companies. Problems in publicity and transparency, and problems in designing the procedure. For example, designing a well object designing in all the documentation from the public procurement. We also found problems in emergency procedures in contracts. We have ordinary procedures that guarantee all the principles for public procurement, but in this kind of special procedure, we don't have these kind of principles. They are not guaranteed. For example, publicity, transparency, because of the emergency, you need to give the contract to a company in a really quick time. So in this case, it's really important to comply with formal requirements. Preliminary market consultation is an instrument that we have in Spain to consult to all the companies how to prepare a documentation for the contract to make the tender in the best way. Well, this preliminary market consultation are not well used because normally they use to fix the price, but not to important or difficult technical issues. We pass now to the award and tendering phase. What risks we have detected? Bidder capacity and conflict of interest. As Sofia said before, conflict of interest is a big problem in public procurement. So it's important to use mechanisms to avoid it. Contract prohibition management. Sometimes companies have prohibition to participate in the procedure of a contract. It's important to know this information, to know that this company is not the one that should participate in the tender. Electronic tendering challenge include capacity, security, or confidentiality. This is again a problem, but I have to say that after COVID in Spain, this kind of electronic tendering is the most followed right now because it's not paper almost used in Spain right now. The importance of the justification of the decision of the award to prevent special procurement appeals. This is really important. Most of the special procurement appeals are due to this kind of not adequate justification. We also have detected that the special procurement appeals are used in a bad way. That's suppose that they are used, for example, in the light filling or in inappropriate grounds that they are not listed on law. And we have problems to access to the decision of the appeals. This is important because it shows the path, what we have to do and what we don't have to do. And we pass just to the last phase of the contract, the performance phase. And I would like to say something before listing the risk. Performance phase is a phase where we can find information. We have really little information. The risks that we have listed are based on the information that we have found, but this information is really, really little. We don't have a lot. What risks have we detected? Risk in transparency and in publication. In the modification of the contract, sometimes we use modification, but they are not the ones that are listed in the law. Problems with subject modification. It's important to have the information when a company merge or when a contract assignment under a specific provision. Information deficiency because we don't have, for example, information in subcontracting. We don't know the weight of the subcontracting in the global public procurement because we don't have information. This is another problem because we don't know if the company pays to the subcontractor in the time and with guarantees, and we can find this information. We don't have information to guarantee that the contract was well accomplished. This is something good that happens because the National Platform in Public Procurement follows one of our recommendations. Now we have a compliance certification that allows us to know that the contract has finished. We also have detected that sometimes we have tacit extended contract that is not allowed by law that made another problem, which is that contract is not can be tendered, so no many companies can get in and participate in the tendering. So some conclusion about the risk map. First of all, risk map is a prevention tool. It helps to reinforcing transparency and legality and promote cultural transformation. That was the goal that we have to try when we create this map. And in conclusion, we have to say, public procurement has a really importance in any budget. We have to manage with a lot of risks to avoid corruption. It's important to enhance integrity and transparency because of, again, the impact of public procurement in economic. And I would like to finish with some quote that Lawrence asked me for all the presentation that I prepared. In public procurement, integrity and transparency are not obstacles. They are the best guarantee of efficiency and public confidence. And I have to thank you to my colleague for the help.
Okay, thank you so much, Olga. It's true that one of the things that you have said, and it's absolutely true, is that when you want to start working in procurement, nobody wants. I have been working in procurement for 6 years, and when I started working, a friend of mine asked me, why? Why do you want to work that? Because you have a lot of pressure about the deadlines, about the things that you must sign. You know, when you give a contract to a company, you have to sign. There is a lot of responsibility, and you are going to earn exactly the same money. Why? So, well, I think it's quite interesting. It's an area that I want to learn about that. And they said, but I don't see the reason why do you really want to do that. So the professionalization is quite interesting. And here, for example, I remember one meeting with Ingesa, that tomorrow we'll have a brief speech about Ingesa. They said that sometimes the problems that they have in the hospitals is the person who is in charge of the procurement is not a person who have a specific knowledge about that. I mean, it's someone who was there, maybe say, okay, you have to do that because there's something that you have to do. And there's not something with a specific profile. So I think it's a problem because this person finally started using the same papers that the person who was there before used it. And that is the origin of case of fraud, but not fraud in that I earning money for myself. It's just maybe I not guarantee, as you said, transparency, concurrency. Okay, thank you so much. And in these things, one of the really important role to be aware about these activities is the whistleblowers. So Manuel, in your, whistleblower is a key pillar of the fighting corruption. So what challenges do you see to implement those measures in Spain, and how important are the measures that other countries can adopt in order to harmonize this regulation?
Well, first of all, thank you very much for your invitation. It's a pleasure to be here with you and with such distinguished colleagues. My organization, my agency has started 4 months ago, and we have to begin from scratch. So I would like to situate, to place my presentation within the framework of the European trends against corruption, okay? And as a member of the European Network Against Corruption, I would like to give you a concept that you know perfectly, the concept of Europeanization. I think that we have seen in recent years a process of Europeanization of the fight against corruption. And this process, you see different institutional changes that we have seen in the recent years in Europe. The only way to understand them is to introduce the concept of Europeanization. There are certain changes, certain institutional changes that you can only explain considering this concept. So the European Union right now is proposing new legislation and working to prevent corruption within these limits established by the treaty. The new European Union anti-corruption measures include, for example, a joint communication on the fight against corruption, a proposal for a directive of the European Parliament and the Council on combating corruption by criminal law, and also a new European Union sanction regime for corruption. So, among others, the new proposed legislative framework in the European Union will step up corruption prevention by raising awareness on the negative impact of corruption on citizens. It will extend the definitions of criminal corruption offenses beyond the more classic bribery offenses, including, for example, also misappropriation or trading in influence, abuse of functions, as well as obstruction of justice and illicit enrichment related to corruption offenses. The new proposed framework will introduce minimum criminal penalties and sanctions for different offenses to ensure a level playing field in all European member states. That's very important. And also, it will extend the statute of limitations to prosecute corruption in courts. Also, it will ensure that law enforcement and prosecutors have appropriate investigative tools and resources at hand to fight corruption. So that's very important to understand all the system that we are facing right now, and also it's very important for my work and for the work of all anti-corruption bodies. In Europe, what we can see also is in the European countries certain new trends in the fight against corruption. For example, I think that we are introducing the evidence approach. We are trying to develop novel evidence-based indicators of corruption. That's very important. we don't have very good indicators, and we have to create evidence-based indicators. Second, we have a risk-based approach. That's very important. Also, you can see here in this Congress that you are working a lot on risk-based approach. It's also very important to introduce more technological sophistication and developing artificial intelligence and data analysis to fight corruption, and also the whole of society approach. And that's where my presentation connect with my work. I think that we have in Europe and in the rest of the world probably a new paradigm. The idea that if you want to fight corruption, you have to introduce preventive institutions and also repressive institutions. And considering preventing institutions is very important to have a holistic integrity system. That means you have to include in the process, in the strategy, not only the government, but also the private companies, the civil society, the political parties, all of them, they have to introduce instruments, processes, and bodies, new bodies to fight corruption. And to have this holistic process, it's very important to consider civil society. We need to improve our work with civil society because it is impossible to fight corruption in the long term if we don't consider civil society, if we don't introduce a social accountability system, if we don't introduce a social empowerment system. And to introduce a social empowerment system to empower citizens is very important. It's very important to give them appropriate measures, appropriate instruments, appropriate channels to send complaints, to send denounces, and also that they feel that they are empowered to fight corruption, that they will be protected if they fight corruption. So it's there where my institution, the new directive and the new law that in Spain transposed the directive come in, and this is the reason why I think we are very important to prevent and to fight corruption, because our role is to empower citizens to denounce corruption, to empower citizens in the way that they feel protected and they will fight corruption with all the other bodies that are fighting and preventing corruption. So the most important mission of my organization, obviously, I would say that is protect whistleblowers, but first, our vision is to contribute to improving Spain's culture of legality. That means that it is important to create, to develop a shared belief in the importance of complying with laws. It is important to create a generalized expectation that others will comply with laws and unequivocal rejections of non-compliance. And second, it's important, obviously, to contribute to the detection of corruption and to promote a social empowerment by providing internal and external channels for whistleblowers' denunciation and protection. So finally, the mission of my organization is essentially that we have 3 or 4 goals. The first goal is to protect whistleblowers with all the system that we have in our law, in the directive. The second is to implement the external channel. That means that all the citizens, especially in our case, all the people who work for different organizations can send us denounces and can send us compliance and information about illegal facts, illegal deeds in their organizations. Third, we have a system of sanctions, very important system of sanctions for people who don't comply with our law. And finally, we have to change the culture of information and to promote a culture of whistleblowing protection. Thank you very much.
Okay, thank you, Manuel. That is exactly true that sometimes we need the civil society in order to be aware about any kind of manipulation of procurement process, for example, or, as you said, in the case of manipulation of public funds. So the civil society, sometimes this is the main source of information that we have. So I think it's quite interesting that they feel safe to denounce the things that they are saying, and if they identify some kind of fraud. Of course, yeah, it's quite important. And then one thing that it says about the Europeization of these regulations. So related with this, I want to ask you, Mark, about how is your idea about this way of collaboration between all the European institutions to fight against fraud?
But, thank you for this opportunity once again. The collaboration across European countries could be sharing our deficit and our fraudsters with other countries. No, it's a joke. It was to look if you were following me. But if you want, we can discuss it. In a system like ours in France, we now face, as I said, organized fraud networks. So that means we don't face individuals isolated, but and I think it's very proximate to what Alex said, professionals of fraud who act all over the country and who bypass frontiers. I mean, local frontiers for France, but maybe frontiers for Europe. Maybe, and it's quite evident, we don't have the same systems, but we have the same problematics. I mean, the budget tension is very important, and the attempt in regards to the population needs in terms of aging and healthcare needs are very significant. So these fraudsters, they analyze our processes, find weaknesses that we don't know, because even if we work a lot on mapping risk, in fact, there are still loopholes that we don't master, and they exploit them systematically with, honestly, what we see in France is fake companies, identity theft, which are used and reused, data breaches, false billing, and recruitment through social media, especially on TikTok. It's a very important trend in France, recruitment of youngsters whose identities are used to commit fraud for criminal groups. So I assume they can operate across several countries, and the risk could become European, and maybe it's already the case, but we don't know it, and we don't know it for a good reason, is that we have to tackle a lot of things already in our local, in our countries, so maybe we don't see it. But I think that a group that exploits a loophole in one country can replicate it elsewhere, and that's why I think the first idea could be to share, to have an institution, a way to share early signals faster together. Because despite good results, I think we all have a good score sheet in terms of counter fraud. If we can talk like that, there is no magic algorithm, and we didn't speak a lot about AI, but I think we all experiment, but it's not a magical wand, and a lot of people, especially in media, etc., assume that with AI now we can tackle all the problem, but fighting fraud takes people, time, and persistence. Fraud is complex, more and more complex, because when we have professional and organized groups, organized schemes are very difficult to identify, whether it's quite simple when you look at one isolated individual. So coordination is also difficult within our countries. I don't know in yours, but We need to have different organizations talking to each other to be efficient. And most of the work still happens on the ground. So I think the HAFCN today brings together the main national health insurers and control fraud agency across Europe. So it could be a good path to map the most frequent fraud typologies, as we try to do today, and to have a way to issue risk alerts and maybe early detection indicators to talk about it, even if it doesn't replicate everywhere, but just to have a common culture of it. So we don't need a single European system. We already have difficulties in our countries to have the same IT, the same system, the same data flows, but maybe a macro perception of what are the trends in frauds could be a good way to tackle the subject, because the money that flows in the system is very important. In fact, we forgot that even if social security is a social pillar, it's also one of the largest economic systems in Europe. Between 10 and 12% of the GDP of all the countries. It's a lot of money, and fraudsters love that. So I think it's important to have that in mind. Maybe just a last word to say that technology to us is an opportunity that fraudsters have already taken into account, and we don't have the same budget to face it. So over the past 3 years, most massive fraud alerts have involved data theft, as I evoked, identity misuse, and increasingly AI-generated forgeries, which means fake prescription and invoices created by artificial intelligence. So we digitalize to have the master of the medium and the media, but it's a run that needs investment, stolen medical identities which are reused, and even social media driven fraud with people who are recruited online to submit fake claims and false sick notes. And these are the same organization than a drug or criminal organization for us. So where we could have also cooperation is that when the fraud is committed, the money flows. And once it has fled in other part of Europe, which could be the case, we could maybe have a more efficient coordination. When we know that group operates in different countries, it could be instructive to have that kind of information. And last, maybe a word to conclude as a conclusion to me is that I joined this European exchanges only 2 years ago, and I must say that they are extremely valuable. Listening to colleagues from other systems help us put things in perspective and identify what we have in common or what could be different. I still remember Alex's presentation 2 years ago in Brussels, and I must admit, I don't imagine that we had so many things in common with our favorite cross-channel neighbor. And also was impressed by the prepayment control system implemented in Cyprus to supervise third-party billing, which we copied in France since we launched 1 month ago approximately the same mailing system. So it was a good idea that we shared and that we heard, and so we took it back to France. And it's a promising perspective.
Okay, thank you so much, Mark. I think it's quite interesting to see how you are trying to be updated. I mean, you are all the time trying to do things in order to fight against fraud, because you were talking about the social media, you are talking about the artificial intelligence, sorry. So it's the way that you are trying to be forward the fraud and the corruption, and just not just in your country, that you are trying to spread this your experiences according to Cyprus, as you said before, Cyprus. So I think it's quite interesting. I don't know if I'm running out of time. 5 minutes more. I don't know if you have questions. Ah. Okay, perfect. So I think we have time for one more question with a brief answer for everyone. So Mark was talking about these new trends, these new projects. So in the case of the UK, what is the last ideas, projects that you are having in order to fight against fraud?
Okay, so we've invested heavily in data analytics. Technology is critical. Mark, you made the point. Let me be clear, there is no fraud that happens in the National Health Service that does not have a digital footprint. Everything is traceable. So in the claims arena, we understand how to find fraud. It's more challenging in procurement and in areas where there's a lot of subcontracting. That's where we're focusing our attention. We think we can offer services to more localized procurement where we can also find fraud. Quick example, we found a case involving transport contracts with a hospital, taxi services, significant corruption, backhanders being provided to the owners of the company. We've seen a similar example with mobile phone contracts in Scotland. All of that is traceable if you invest the resources in the right place.
Okay, thank you. Yeah, here we are working too in the digitalization of all the process. Right now, everything must be signed electronically with a certificate. So yeah, we are working exactly in the same way, because I remember when I started working in the administration, at that time everything was signed on paper, and it's easy manipulated. Okay, and in the case of the Seneca, how are you coordinated with other national and international European bodies to fight against fraud?
Okay, as already said, we are the coordinating body with OLAF, the European Anti-Fraud Office, and we coordinate with them. We provide or coordinate the assistance to this office before, during, and after the investigation. For example, responding the request of information from this office on cases under investigation or prior to the opening of an investigation. Also, we assist OLAF during on-the-spot checks here in Spain, after the investigation if needed. At national level, to be brief, the most important measure is to have strong anti-fraud governance structures, of course, that are very useful to bring together all the relevant actors and creates the foundation for a place to share the experience, good practices, and the expertise between all the actors. In our case, we have a body that we call AFCOS Network. AFCOS is the name of our unit by its acronym in English. AFCOS Network, as I said, that is the advisory council for the prevention and fight against fraud, a collegiate body that assists our unit and includes all the relevant actors in the fight against fraud in the different institutions and bodies within the public administration. Also, the Spanish network of anti-fraud and offices and agencies, made up by different offices or institutions at state, regional, and local level. It's an example of a network very useful for the exchange of experience and good practices between peers. And we have also coordination with other national institutions, for example, the Civil Guard, the law enforcement body, Civil Guard and National Police are the ones here in Spain. We have protocols signed with them for the same reason, no? to establish the basis of the collaboration and to exchange information in matters of mutual interest. Thank you.
Okay, thank you. And we are talking right now about the relation between different institutions or bodies. So in the case of Oirescon, how do you think can European bodies or institutions better align procurement in order to reduce the risk of fraud?
Well, Oirescon is a national body, so we don't work directly with Europe. So I cannot tell what bodies. Actually, if it's not, or I don't know if it's a network between supervision bodies in Europe. I think it is not existing. But what we have participated is in the procedure that the European Union opened about the directive in 2014. So we have made some proposals due to organize or to increase or enhance public procurement in Europe. So, for example, we have proposed to impulse the strategic aspect of the contracts, because nowadays, as I said before, it's not really working and it's not making this impact on strategic. We also encourage the presence of a small and medium enterprise in public procurement, because it's really difficult for this little and medium enterprise to participate because they don't have the sufficient media to be in a really complicated procedure. We also improve professionalization. As I said before, it's really important to the professionalization of the actors in public procurement, and as you said before, the incorporation of commitment to integrity as a strategic core aspect. The directive in 2014, they create the concept of conflict of interest. Then the law take that concept in Article 64. So I think we have to keep on working in Spain and in Europe about integrity in public procurement. The improve of the information and the quality of data, as I said before, because it's the only way to really analyze the problem of public procurement and to take decisions. Nowadays, the data is not well, and it's a good area for the artificial intelligence, I think. And also improve the framework of supervisory bodies, because, as I said, I don't know if it's a network in Europe. I don't think so. It's not a very communication between bodies. And I think this network is important because it's a way to exchange experience and knowledge. So like the network you have here in the healthcare sector. And I think it's really important to have this knowledge from different countries and to impulse a different solution for problems that we have detected.
Okay, yeah, as I see, maybe the collaboration is more informal between countries more than institutionalized in the European framework. No, it's not coming from the European institutions, so maybe the collaboration is more like this, no, like this network between countries more than maybe the Commission improve this collaboration. And I want to ask to Manuel about the whistleblowers. According to your experience in the months that you are working in the agency, what do you think are the barriers that they are right now, cultural barriers I'm talking, in order to protect whistleblowers? You said before, and we were talking about the necessity that the whistleblower feels safe and protected. So what things you are feeling that are over there related with the protection of the whistleblowers?
Well, we will be very brief because we are running out of time. Well, I think the most important thing is to avoid retaliation. Once the retaliation begins, everything is bad. No, people are suffering, and we have to avoid the retaliation. And now we are trying to change our law, to introduce certain changes in our law. avoid this retaliation, for example, to be able to cancel the dismissal of people before this dismissal is fully implemented, and also to introduce in certain penalties for people who retaliate people. So these are the kind of things that we are right now trying to introduce, and also to implement the law. The law can help us to protect people, because, for example, we have to give them certain health services, especially psychological support. We have to. They can do that in an anonymous way, so they have a lot of protection from that area. So there are different things, but for me the most important thing is to avoid retaliation before the retaliation begins. Okay.
Okay, I think that we have time for one more question. Shumar, no? Yeah? Okay. So I want to ask you about what are the challenges that right now the European countries have in order to fight against fraud? I mean, collaborating cross-border between the countries. So what's your opinion about that?
Thank you for this question. For me, European cooperation is not a silver bullet. So silver bullet is used to kill vampires, for those who don't know, but this cooperation can be one of the levers we can activate step by step, because we feel that our challenges are very unique very often, but in reality it's good, we know that it's good to share, and many of us face the same issues, complex billing chains, digital vulnerabilities, because every transaction has a digital footprint now, it's clear, and for France, but I assume in other countries too, there is a public pressure, very important, for zero fraud, because in a period of budgetary tension, assuming that people are deviating in a part of their contribution to the system is intolerable. So in France, healthcare fraud has become a highly visible topic in the media, in politics, in public debate. It's one of the national priority, and our current focus is to strengthen our own processes with data analysis, with early detection process and preventive controls, which are key, and obviously make sure that we build a system which remains accessible. So yes, European cooperation matters, but to be realistic, as I said, we already have a lot to deliver at home. So I think that European cooperation should not replace the national action. It's a dream to imagine that in fraud we would have success that didn't happen in other part of European cooperation, but it should amplify it, and understanding how others detect, prevent, and sanction fraud, kind of collective intelligence, is already a form of cooperation. So we can still share methods, technologies, especially regarding AI experimentation, and lessons learned to achieve a better return on investment for everyone. So I think the real return on investment of cooperation is more knowledge than an infrastructure that we will not have the means to put really in place. And so in practical terms, I see two key priorities. First, to maintain a regular information channel like today, and that could happen at different time of the year, but I think it is the case. So to share concrete risks and solutions. And second, to ensure that European regulations, especially on data protection, digital identity, AI, actually help rather than slow down our anti-fraud work that can sometimes be the case.
Okay, thank you so much. So, I think, like a resume, I'm going to say some highlights that I have written down that I think that we are all agree after this interesting intervention in this panel discussion. So we have identified several areas that are really important in order to fight against fraud, because they could be victims of this fraud. That is the case of the procurement, frauds in the public aid, and all of them are influenced by the conflict of interest in all these different areas. So we identify the necessity of professionalization of the people who are working in the management of the public funds, not just in the case of the procurement, but even in the public aids. Then we identify two really important point, in the case of the resilience and recuperation funds, that we assume as our own identity some criteria or some ideas coming from the European Union against fraud, but at the same time we miss a role of coordination of the European institutions in case of, for example, protection of the whistleblowers, or for example in the case of the procurement too. Mark has said a couple of times the importance of technology and the artificial intelligence as an opportunity that we must take into account in order to fight against fraud. And the importance, as said Manuel, the importance of the civil society and the role of the whistleblowers in order to fight against fraud. So finally, I just to say thank you to all the speakers. Thank you for your collaboration and your time. And I don't know if we have any questions. Okay. Thank you so much.
Thank you very much for our moderator, David, and the 5 speakers. We have a special moment now. We want you to meet two new members. One comes from the Netherlands and one comes from Iceland. One of them has already been here on stage, but I'm going to call him again, and they will both hopefully say just a few words. So I would like to call on stage the new member, Eugen van Mierlo from the Netherlands, member of the Board of Directors of IKZ, the Healthcare Fraud Information Hub, who's here. And I would also like to call Jurkra Siguru Helgason, mind my accent, CEO of Iceland Health. Can you please come on stage?
Yes, let's see if it works. Yes, well, good afternoon again, ladies and gentlemen. Let me introduce myself again. My name is Eugen van Mierlo. I am member of the board of the Information Hub in the Netherlands, and next to that, I am deputy mayor in one of the cities in the region of Twente, in the east of the Netherlands, close to the German border. It's a real pleasure to be here and to introduce our organization, in Dutch called the Informatieknooppunt Zorgfraude. I'm going to ask some of you, of course, during the next break to pronounce it, just for fun. But no, in English it's called the Information Hub for Healthcare Fraud. And initially we were a public partnership in the Netherlands. And since this year, January 2025, we are an independent foundation. And since last year, we have joined the EHFCN network, and something we are, of course, very happy about. Let me start with who we are and what we do. The Information Hub was established under Dutch law, and you see the name of it on the screen, which is the law on promoting cooperation and lawful care. That law gives us a clear legal foundation to share and to combine information between different authorities in the Netherlands in order to fight healthcare fraud more effectively. In practice, it means that we collect and that we process fraud signals from a wide variety of organizations, such as healthcare insurers, the healthcare authority, inspectorate, municipalities, and we enrich those signals by connecting the dots, as I said in the panel discussion, and by combining fraud signals about healthcare providers and making sure that information is as complete as possible. And then we share that enriched information securely with the relevant partners under strict privacy and security rules. And our role is not enforcement, but we make enforcement possible so that the right parties can act based on a full and reliable picture. And next to working with the fraud signals, we also have a research team. And this year, for example, we published a report on turbo liquidations in the healthcare sector. And there are, of course, many, many topics to research on. The Information Hub is literally a hub. We have many partners and we connect many actors who all have their own role in our healthcare system. And you see 9 dots on the screen, 9 dots with names in it, but there are many more partners than just those 9 on the screen. For example, one of them, and I told it before, the municipalities, we have 342 of them in the Netherlands. And what's important to know is that we have partners in, let's say, 3 sections. Organizations that have a focus on criminal investigation, organizations that focus on contracting healthcare providers and assessing care needs of the many people, and also organizations that focus on supervision and enforcement. And how does that process work? When a possible fraud signal comes in, our team performs a triage. We check whether it's credible, whether other signals exist on the same healthcare provider, and whether there is overlap between, for example, regions or institutions. And this exchange of information helps prevent duplication of efforts, and it also allows our partners to coordinate their response or enforcement. Well, what do we bring to the EHFCN network? First of all, experience as a central point of contact for many partners, both public and private, in tackling healthcare fraud. Second, I want to mention structural cooperation between the partners at all levels, from policy design to day-to-day operational work. And third, a dedicated research team that looks into trends, into typologies, and new forms of fraud. And we would be very interested in connecting our research capacity to European projects or comparative studies across other countries. And of course, we also hope to learn from you. We are particularly interested in, let's call it operational context, so that when cross-border elements appear in Dutch cases, we can reach out to the right colleagues in your countries. And, as I mentioned, I live close to the border with Germany, and my municipality knows that there are criminal networks cross-border, also with connections to the healthcare sector. And we would also like to exchange insights from research projects, for instance, about behavioral patterns of fraud, the use of AI or data analysis, or ways to evaluate preventive interventions. And finally, of course, we want to learn from your successes, how, for example, you have organized supervision, how you ensure ethical healthcare topics, and how you build trust with the sector. And a day like today gives all those insights and is very, very valuable also to our organization. So in short, and then is this my last slide. In short, the Information Hub connects people, data and knowledge to try to achieve that the Dutch healthcare system remains fair, remains transparent and lawful. And we strongly believe that cooperation is the only way to tackle fraud effectively. And that is just the reason why being part of this European family is so valuable to us. Thank you very much for welcoming us, and I look forward to working with many of you in the near future. Thank you very much.
Yes, hello. I want to start by saying that we're very pleased to be here. We find this very interesting and stimulating, and we want to thank the organizers for a good conference. A lot of the themes that we're hearing here sound familiar to us, and we're looking forward to becoming members, full members of the network, and participating in the work of the network. Now, I wanted to take the opportunity to tell you a little bit about our agency. Not so much about control, not so much about fraud, but more broadly, since we're new, about our role and the organization of the Icelandic healthcare system. Iceland Health is the national health insurance agency in Iceland. And as a small country, we have a more centralized approach than in many countries that we have been discussing today, which has its benefits, of course. We have an overview of the whole system, which is maybe lacking in bigger countries. We provide universal health insurance to all the residents of Iceland, and the system is tax financed through the central government budget, so there are no social contributions from employers, and nor any insurance premiums from individuals. It's totally tax financed. The main role of the agency is to provide services to safeguard health, ensure equal access to healthcare regardless of income. So a very big emphasis is put on the social aspect of our healthcare system. We are pooling risks. We are providing health services for all. We are also meant to contribute to operational efficiency and optimal use of healthcare resources, which is of course a vital task, and to promote high quality of service, which is very challenging, as you are well aware of. Now, the reason for this organization is to strengthen the role of the state as a purchaser of healthcare and to ensure cost transparency, which is also a very important role for us. Now, what we do from day to day, we contract for healthcare services and goods based on policy guidelines provided by the minister. So we are under the leadership of the minister. And then we pay for healthcare services that are provided by a range of providers. And then we monitor quality and effectiveness of the services, and included in the monitoring is, of course, to detect fraud and other irregularities in the delivery of services. Now, if you look at the characteristics of the Icelandic healthcare system, we are based on high level of public funding, so there are relatively low out-of-pocket payments. There's no voluntary additional health insurance, so basically everything is paid by us. And there's a high level of choice. People can basically go where they want, and there's limited gatekeeping. So this is a challenging organization. It's challenging, for example, to ensure cost control in such an open and flexible system. It has its benefits, but it's difficult to control. Now, the financial scope, maybe the number giving the most insight is that we manage around 5.5% of GDP in Iceland. So that is our volume of expenditure. And we channel roughly 2/3 of the total government spending on healthcare. So some of the state-run health services are financed directly through the budget, but we take care of the 2/3 of the total healthcare budget. We're a small organization. We only have 140 staff members, and we are we consume a relatively small share of the total budget, around 0.6% of the total budget. And we are stressing in the public debate in Iceland that the infrastructure we're responsible for requires more funding. For example, we want more funding to improve controls in the system. But that is a challenge for us to get an understanding that you need to have framework for the systems and not only pay for the services. Our operational scope is wide. We manage payment systems for primary healthcare, specialist hospitals and services for the elderly. We administrate out-of-pocket payment systems, both for medical products and general healthcare services. We have extensive direct services to the public, although most of the services is provided, of course, and directly through the service providers. We manage IT systems and digital services with high degree of automatization and self-service. And we process around 1 application and 30 payment-related transactions per inhabitant each year. So for a small country, it's a big volume. We managed around 300 contracts, not including that many contracts have subcontracts, so they are in fact more. And we manage contracts with hospitals, primary healthcare centers, services for the elderly, specialist outpatient services, rehabilitation, medicines, etc., etc., etc. Now, these services are provided by a range of providers, both public, private, and sort of NGO-type providers. So we have a mixed system in that sense. We use a range of payment methods, fee-for-service, DRG-based payments, per capita payments, or, what is called capitation payments, payments based on RAI assessment, and also through global budget to individual service providers. Now, last, a little bit about our challenges. We're supposed to have contracts with all service providers, but we haven't finalized contracts with all public providers, so that's a challenge for us to finalize that job. We are trying to develop more balanced payments methods. The healthcare is basically financed mostly through fee-for-service and global budget, but we want to have more balanced approach to the payments. We want to concentrate contracts on fewer and larger providers so that we get stronger entities within the healthcare system. And also, of course, we want to improve the operational efficiency of our agency and strengthen focus on key roles. I mean, we have many roles, but we have to have focus on our key roles. One of the main challenges, of course, is to improve contract implementation, surveillance, and control. It's often you put a lot of work into new contracts, but when you have finally achieved a good contract, you move on to the next one, and you maybe neglect the implementation phase, which is, of course, equally, if not more important. So we are constantly trying to ensure the services are evidence-based and that they correspond to the needs of the public, which is not an easy task. We want to focus more on quality, improving cost and budget control, which is, of course, vital in our current environment. And, of course, and lastly, countering misuse and fraud. Of course, like all of you, we encounter both misuse and direct fraud, I would say, both from service providers, from users, but also, unfortunately, I have to say as well, from our own staff. So it's a challenge to try to counter misuse and fraud on all levels, but we're trying our best. The use of information technology, IT systems is crucial. Paper-based processes, which are few, but they are more risky than the rest. Cross-border transactions are risky in our opinion and deserve more attention. And of course, having a high level of automatization where you don't control before you pay also has its own risks, and we have to counter that. So this is just a short overview of who we are, and we are very much looking forward to the cooperation. Thank you so much.
Well, congratulations to the new members for taking part of this European family. We're finished. It's been a long day, and we need a special wrap-up from somebody that knows very well the European Healthcare Fraud Corruption Network. In fact, we have 5 special guests within this audience, former presidents of the network or very special people for the network. So let's hear the final remarks from the former president, Sotiris Bersimis, professor at the University of Piraeus in Greece.
This one? Yes. It's better to look there. Maybe so. Okay, thank you. First of all, I would like to thank the President and the Board of HFCN for the invitation. I'm very happy to be here, and also I feel honored that I served as the President of the HFCN for approximately 1 year before approximately 8 years, if I remember correctly. So you asked to give some final remarks and final, comments that from this day. I have prepared some slides for this reason, and I would like everyone to know that in every slide that I had the privilege to see today, there is always something new to be a new knowledge, something new to know also for me, I suppose it's for everyone. So today, we explored diverse European perspectives. We heard things from policymakers, regulators, and practitioners. And we share one common goal: integrity in the healthcare sector and in health insurance and everything that it is intersected and related to this. So integrity, as we learned today, must be built by design. We have to collaborate because collaboration transforms the culture. And we need to, to cultivate a new culture that will be specific to, to find, to detect, and to, if it is able to remove fraud and waste from this network. Technology seems to be a necessary base for all this. We listen from people from Luxembourg that they have new system. In every country, there are advanced systems, technological systems that permits let's say, to monitor everything that happens. And we heard that data is not only evidence, but it is empowerment. Actually, as a professor of data, analytics, statistics, and all of this, I tried to avoid to speak about data, but everyone here was talking about data, about data-driven fraud detection, and everything. So I will give some, let's say, some small, let's say, wrap-up of this, and I will put some details from myself. So fraud, we listen that fraud detection is data-driven, and also prevention is data-driven. Prevention of fraud and prevention in the context of health. I could say that let's say, the quality in the healthcare provision is somehow inverse analogous in the fraud, in the quantity, the amount of fraud existing in the system. So analytics can give the signal and also translate the signals to action. Any signal can be reformed, transformed to strategy to be proactive. So also, data and transparency always go together and can also empower the public trust. You know, when you don't have data, you cannot be transparent. So we listen about advanced data analytics. In our last panel, we heard about machine learning and AI. And before that, we discussed that all these methods can reveal hidden patterns and detect anomalies. But keep in mind that every anomaly is not fraud, and fraud is not only anomalies in the context of data science. So claims, from claims to compliance, we can do evidence-based prevention of fraud. And of course, because we are discussing for at least for data, we can say that before 8 years, data were about only what we can see in a database or in an Excel, something like this. But now, when we are talking about data, we are talking about the text, the emails, for example, that are coming in a whistleblowing system, or the images that can also be assessed for fraud. So data are together with integrity and ethics. So I heard the terms data quality. Data quality. Data quality is essential in order to apply analytics. Of course, we are very privileged that we are living in Europe, so we have GDPR, AI Act, so everything is, let's say, to protect our people, our European people, and also to, let's say, to be transparent. So another thing that we have to look at is the collaboration among institutions. And actually, data sharing is such a collaboration framework. So we can frame a new collaboration scheme based on data. Actually, protecting the data and exploiting the data for the good of the citizens, so protecting confidence in the system. And let's go further. If we are talking about analytics, every claim can be, let's say, flag suspicious cases. Network analysis can expose networks and criminal networks and all of this. And if we are talking about analytics, we can see something like this in order to identify the fraud, or image analysis in order to identify, again, fraudulent cases. But as I already mentioned, because we have discussed about collaboration, about the exploitation of data, I feel that, as I told you, that cross-border exchange of data can improve capabilities, also can frame a collaboration scheme.
Standardization also of data, of KPIs, can also help us what to do to, let's say, to benchmark, to identify, to see what happened from country to country, from area to area, because this is not the fraud in the healthcare system is not a, let's say, a privilege of the public domain. Exists also the fraud, the waste, the abuse also in the private sector. So from my point of view, it's about partnership between payers, regulators, academia, and everyone that it is a stakeholder on this, let's say, network, and can help in order to identify and also fight fraud. So from my point of view, the future is a European framework for fraud and fraud analytics. So because we discussed a lot about data. It's not only about data, because every, as we can understand, behind every system there are people. So here we have professionals that they are committed to integrity, to the fight of fraud. We have here people that they are working with whistleblowers, investigators, also people that they are from the side of analytics, auditors, and more. Everyone is dedicated to integrity of the system. So united by a purpose, protecting healthcare services, because healthcare resources is the base in order to provide quality services. Quality healthcare services, as I already mentioned, it is the measure of quality is inverse to the fraud, to the existence of fraud. And now we are coming to EHFCN. EHFCN started as a collaboration between countries, a cross-border collaboration which strengthens resilience, and also EHFCN is a connector, connects systems, connect people, connect more than everything from my side, ideas. So it can push everything ahead in as I say here, EHFCN can make the European health ecosystem stronger. So if we look behind, we can see that EHFCN gives us knowledge, trust, and cooperation. Too many people that interacting, they are exchanging knowledge, and they cooperate under a common target. So the foundation of 20 years of EHFCN gave us 2 decades of collective impact, gave us at least a very big number of initiatives across Europe, and also a network that has grown from idea to institution. I feel that everyone knows that before 20 years, it was just an idea, it was just an action. So now it's a network with too many people working on this. I'm pushing the button. Oh. So EHFCN prepared these 2 videos.
Healthcare fraud is evolving quickly, and sharing knowledge about fraud measures and digital skills is key to keeping up with the development. For 20 years, EHFCN has been a valuable European partner, and we look forward to continue to collaborate in the future.
Fraud in any form is unacceptable, and healthcare fraud is no exception.
In Cyprus, such matters receive a lot of publicity, as our system is relatively new. This increases, however, awareness of healthcare fraud, which is a good thing. Every euro lost to fraud is a euro taken away from patient care and system improvements. We all have a duty to report fraud, to protect both the healthcare system and the people it serves.
Yeah, I think fraud in general is a very bad thing, especially when it comes to healthcare. I think everybody loses, and I think that we need to make sure that we are protecting public funds.
It's a great idea of the agency because they are trying to recuperate the money of fraud and corruption for the patients.
Healthcare fraud, so that's like fake doctors, is it not?
Close. It is when companies or people cheat the healthcare system, for instance by claiming money for care that wasn't actually given.
So they're stealing.
Exactly, they are. It means less money for real care for people who need it.
Well, that's wrong. I mean, those people work hard for their studies and their jobs, and there's rich people stealing off of them. Well, they need the healthcare. That's wrong.
Yes, it is. And that is why we work together in Europe to counter healthcare fraud with the EHFCN, a network that celebrates its 20th anniversary.
Wow.
In France, there is more and more information campaigns to make us aware of fraud in healthcare. I think that healthcare fraud is a problem we must address. For example, doctors who charge health insurance companies several times for the same procedure, or dental clinics that deliberately damage patient teeth to charge them in order to have their teeth repaired. Ultimately, citizens are the ones who suffer from the consequences because the burden of this fraud can unbalance the financial balance of the health insurance system. We must all act at our level to fight this fraud. For instance, recently, measures have been implemented to fight against fake sick leave certificates.
This is the south slope of Acropolis in Athens. Here was the sanctuary of Asclepios, the ancient god of medicine. Many patients spend their night here, believing that the god will come to their dreams and cure them. Since the 5th century BC, so many things have changed. One has remained the same. Health is the most valuable thing in life. Equal access to healthcare services under safe medical conditions and clear procedures are very important. It makes me feel secure if I know upfront what to expect when I make a medical appointment. Am I fully covered? Are there any extra charges? What if something goes wrong? How can I report the case? AOPE could play a key role in the process. After all, the responsible citizen is the informed citizen.
I think healthcare fraud is pretty frustrating. It's trying to scam the system by billing for actions that never happened or overcharging for treatments. And I think that kind of behavior wastes a lot of money that could have been used to help people who really need the medical care. It makes healthcare more expensive for everyone else because the costs get passed down to the patients and to the taxpayers. And sometimes it can even mess up the quality of care if doctors and hospitals are too focused on making money instead of helping patients. Overall, it's unfair and really needs to be addressed so healthcare can be better and more affordable for everyone.
Fraud in healthcare is a serious threat to the integrity and sustainability of the system. To ensure long-term financial viability, governance must orchestrate a comprehensive set of measures. And amongst these measures, an effective counter-fraud management program is essential. We must show that we protect the resources of the system, and we must show that that fraudulent behavior is actively sanctioned.
And we have a second one.
despicable. It's money that is prepared for the needy and you steal it. How can you do that?
What do you think of fraud in social security?
I think that kind of fraud is very antisocial. It creates extra costs for society, and in the end, it is the taxpayer who pays the ultimate price of that kind of fraud. And also, the people who really need it get less than they deserve if many people take advantage of the system. So, yeah, that's my take on it.
How can fraud be tackled?
I think with good regulations and strict reinforcement of those regulations, that kind of fraud can be managed. And if people are in violation, it should be properly sanctioned.
My investigative career has equipped me with extensive knowledge that I now channel directly into protecting our healthcare services. Fraud isn't just about money, it's about people. Every pound stolen from the NHS comes directly from patients, families and vital services. This drives my passion for this work.
Gefeliciteerd met jullie jubileum.
Gelukkige verjaardag IHFCN.
Alles Gute zu deinem Geburtstag, EHFCN.
Gelukkige verjaardag EHFCN.
Χρόνια πολλά, EHFCN.
Bon anniversaire, EHFCN.
Happy anniversary EHFCN.
Buenas tardes para todos. Quería desearles un gran feliz aniversario a la agencia EHFCN de todo corazón.
Drogie HFCN, wszystkiego najlepszego z okazji waszej rocznicy. Jesteście piękni, 20-letni. Wszystkiego dobrego pozdrawiamy z Polski.
Χρόνια πολλά, EHFCN.
Hamid με Amalet, EHFCN.
Χρόνια πολλά.
Well, I hope you enjoyed the videos. Thank you very much. We're now over. Muchas gracias por estar hoy con nosotros. I would like you to enjoy the visit of the Prado Museum for those joining, and of course, the party celebrations. Let me just remind you, if you can, come a little bit before tomorrow morning, because you'll be coming with your suitcases and you have to pass them through the scan, like the airports, okay? So just to make sure that you'll be here on time. Enjoy Madrid, even though it's raining. Thank you. Hasta mañana.
For those that go to the Prado Museum, we see each other here in 10 minutes outside of this building, and then we will cross to go to the Prado Museum, okay? You can see with Peter Jan will be there. And the other ones, the dinner starts at 8:15 in the Hotel Atocha.